Thank you very much. You can sit. And I now introduce Sir Trevor Hassell to give his welcome address.
Dr. Gloria, Giraldo, NCD and Mental Health, Caribbean Regional Advisor of PAHO, Dr. Joyce St. John, Executive Director of CARPHA, Professor Rohan Maharaj, HCC Alcohol Policy Advisor, and Professor of Family Medicine at the University of West Indies, St. Augustine, delegates, attendees all. Today it is my pleasure to bring greetings on behalf of the directors, member organizations, volunteers and staff of the Healthy Caribbean Coalition as we and our partners host today's conference in recognition of the 8th Annual Caribbean Alcohol Reduction Day. Today's event is in many respects unique and merits special recognition, for it is one of a small number of regional multi-stakeholder conferences held in the Caribbean to address the harmful effects of alcohol in the post-independent period. Alcohol is a highly prevalent and complex factor recognized to cause several adverse health effects. The WHO Global Status Report on Alcohol and Health in 2018 shows a prevalence of heavy episodic drinking of 36% in males and 9% in females in Caribbean people 15 years and older, and the prevalence of alcohol use disorders of 12% in males and 5% in females. Alcoholic beverages are an important commodity rooted historically, culturally, politically, and economically in the Caribbean, with powerful players that influence policy decisions and shape social norms, providing employment, profits, and tax revenues through the production and sale of alcoholic beverages. Perhaps no other risk factor for NCDs specifically and public health in general presents a greater challenge for effective and meaningful public health policy making than alcohol. National alcohol policies are virtually non-existent in Caribbean member states. This is unfortunate, since a well-designed national alcohol policy can have a significant impact on safeguarding the health of citizens and promoting a healthier and more productive society. It can help reduce alcohol-related harm, prevent underage drinking, and promote reduced or no consumption of alcohol. A comprehensive national alcohol policy, then, would be expected to address issues such as pricing, availability, marketing and advertising, and education and awareness. The HCC has sought to heighten awareness of the harmful effects of alcohol and actions needed to reduce such effects. And over the past 8 years, initiated and hosted an annual Alcohol Reduction Day together with its regional partners. Today's conference, led by Professor Rohan Maharaj, HCC's volunteer alcohol policy advisor, is a continuation of the HCC's regional advocacy efforts aimed at securing national policies and regulations for the control of alcohol in the Caribbean. And so over the next several hours, as an update on regional progress and priorities in alcohol policy development and implementation is provided, and alcohol research showcased and discussed to better utilize research in advocacy, I personally look forward to the many and varied presentations and discussions and the recommendations for action that will result from today's conference. And so I wish everyone present, both in person and online, a highly successful conference. I thank you.
Good morning, everyone. Hi, I'm Dr. Stephanie Date, and I am honored to introduce the next speaker. So we have Professor St. John. Do we have Dr. St. John on the line? And Dr. Giraldo?
Yes.
Yes.
I'm
yes.
on the line, but I'm not professor. I'm just Joyce St. John.
Today we have professors, doctors, we have everyone here today. So coming up next, everyone knows a familiar face. We have the Executive Director of CARPHA, Dr. Joyce St. John.
Thank you very much, Madam Master of Ceremonies. Sir Trevor Hassell, President of the Healthy Caribbean Coalition, Dr. Gloria Giraldo, NCD and Mental Health Caribbean Regional Advisor at PAHO, Professor Rohan Maharaj, HCC Alcohol Policy Advisor, Professor of Family Medicine at the University of the West Indies, St. Augustine campus, partners, researchers, participants, good morning. It is a pleasure to be here today to address you at the Caribbean Alcohol Reduction Day, CARD 2023 Hybrid Conference on the harmful use of alcohol in the English-speaking Caribbean. This is a critical issue that has far-reaching consequences for individuals, families, and communities across our region. We know how much Caribbean people love to fet, lime, bacchanal, and rum is usually invited as well. We have rum festivals all over the Caribbean. But the English-speaking Caribbean is facing a particular challenge with alcohol misuse. According to the World Health Organization, Caribbean region has the highest per capita consumption of alcohol, 7.6 liters in the entire region of the Americas. Compare this to 7 liters in North America and 7.2 liters in South America. This high consumption is associated with a range of problems, including high rates of alcohol-related accidents and injuries as a result, alcohol-related road traffic accidents. The global prevalence of alcohol dependence is 5.0%, with a range from 2.3% to 7.7%. The Caribbean has a higher prevalence of alcohol dependence than the global average. A 2016 study found that the prevalence of alcohol dependence in the Caribbean was 6.8%. This means that nearly 7% of adults in that time period, and I'm sure it's more, in the Caribbean have an alcohol use disorder. Excessive alcohol consumption can lead to a range of health problems, including liver disease, heart disease, cancer, and mental health problems. These problems have a significant impact on the lives of individuals, families, and communities, and also contribute to poverty, crime, and social unrest. Don't forget, they also overwhelm our healthcare systems and weaken our economies. But what have we done at the CARICOM regional level to propose policy initiatives to mitigate against these startling statistics? Addressing the harmful use of alcohol in the English-speaking Caribbean requires a multidisciplinary and multi-sectoral approach. CARICOM, under the direction of the joint COTED-COSOD meeting of 2019, has convened an intergovernmental working group on alcohol of which CARPHA is a member of the supporting secretariat along with the convener, CARICOM. This group is to explore best approaches to influence policy in an effort to reduce the harmful effects of alcohol use in our region. Right now, the Intergovernmental Working Group dealing with unhealthy diets is the focus of work. HCC has been the main regional entity addressing alcohol through its annual campaigns, which CARPHA has supported. This is why I am so pleased that this year, HCC has convened this type of forum where research about our Caribbean problem can guide policy and programming to solve the problem. We need to explore mechanisms to prevent alcohol misuse from happening in the first place. This can be done through education, public awareness, but it's really about behavior change. And therefore, the policies have to be smart in a way to support behavior change, some of which is culturally ingrained, and support also the restriction of access to alcohol for minors and high-risk drinkers, while we provide effective care and treatment for those who misuse alcohol and are affected by it. We cannot ignore the mental health effects of this misuse. Therefore, social support services should be an integral part of the discussion when strategies are being implemented. CARPHA continues to be committed to working with all partners to address the harmful use of alcohol in our member states. We will be working to develop and implement evidence-based policies and programs that will reduce alcohol misuse and its associated risk factors. We will do this through event-specific and seasonal health promotion messaging to create a healthy environment. I wish you all a productive and information-filled conference. Unfortunately, I cannot stay because I have other meetings, but I hope that you all enjoy what you will experience today for me. Thank you.
Thank you so much, Dr. St. John. I think all of us here are excited after that. We're ready to go. So thank you so much on behalf of CARPHA for coming and giving us some opening remarks. Now we're going to have some greetings from the Pan American Health Organization, and to do so, we have an advisor in NCDs and mental health at PAHO. So I'm going to invite Dr. Gloria Giraldo. Welcome and thank you.
Thank you very much, and I salute Sir Trevor Hassell, President of the Healthy Caribbean Coalition, Dr. St. John from the Caribbean Public Health Agency, and Professor Rohan Maharaj, as well as you, colleagues, members of the academia, and civil society and other partners. Good morning. I wish very much that I were there with you. I'm in a different time zone and in a different climate. However, it is an honor for me to participate in this 8th edition of the Caribbean Alcohol Reduction Day. And I look forward, I'll be learning so much because it will be my first experience. However, I know that PAHO has been supporting this series of events for a number of years, and we'll be hearing today about that history of events such as today's. And they embody the great persistence and the stamina of the organizers, because it is a topic that, as in families, in my own family, we don't want to talk about it. We don't want to talk about alcohol. And it seems that this is reflected as well in our societies. Therefore, having and maintaining, even if it's one of the few forums where this is spoken about, and more importantly, like today, research that is being conducted locally to show and to guide policy development is of utmost importance. We also support that the research that will be presented can guide policies that will be conducive to achieving healthier communities where healthier citizens will thrive. We know that the risks and harms associated with drinking alcohol have been systematically evaluated over the years and well documented, as you yourselves will be showing today through the different research presentations. This year, as you know, the World Health Organization published an important statement in the Lancet Public Health, very boldly saying, when it comes to alcohol consumption, there is no safe amount that does not affect health. So with that premise, the importance of today's forum is even more important. As has been described by the previous speakers, the Caribbean region faces unique challenges in tackling alcohol-related harm, from health consequences, social economic impacts. The need for comprehensive strategies and collective actions is paramount. The time is ripe for collaboration, innovation, for creativity, so that we can sustain or engage in sustainable efforts towards meaningful change. As we gather today, from PAHO, we reaffirm our commitment to address the challenges posed by harmful alcohol consumption. We acknowledge that today's conference is meant to continue to encourage governments to work towards achieving the targets delineated in the Global Alcohol Plan of Action 2022-2030, which was reviewed in depth a year ago in this very same space. And we also commend the civil society organization, the healthcare professionals, the academics, and communities across the Caribbean who are working very hard to place this issue as a forefront issue and to generate awareness, to advance policies and interventions aimed at reducing alcohol-related harm. Your dedication forms the cornerstone of our collective efforts. Today, we reaffirm our resolve to continue to educate and empower communities with knowledge, emphasizing the risks associated with harmful alcohol consumption. We advocate to the implementation of policies that are evidence-based, that regulate alcohol marketing, availability, consumption, the safeguarding of well-being of our citizens, and the implementation of the package, the technical package SAFER, which highlights the most cost-effective interventions in this area, and it's probably very familiar to you. And the support and care to those that have been affected by alcohol misuse and the harmful consequences, to ensure access to quality care, treatment, and rehabilitation services. The Pan American Health Organization stands with you, committed to supporting the Caribbean region in its journey towards healthier and more resilient communities. I wish us a very productive conference, knowing that our collective actions will pave the way for a healthier Caribbean. Thank you very much.
Thank you so much, Dr. Giraldo. So next, we have someone who should not be a stranger to anybody. I'm going to invite Professor Rohan Maharaj, who's the mastermind behind today. He's acting as the HCC Alcohol Policy Advisor, and he's going to be asking a very important question this morning. How does alcohol cause harm? Professor Rohan Maharaj.
But have the slides. Yeah, let's go. Okay. I'm not seeing them here. Okay. Good morning, everyone. Thank you very much, Stephanie, for that welcome. I just need to, all protocols observed, because we will go through the whole idea of greeting all the people who are out there. But there are a few people I want to especially greet before I start, and that includes members of the UWI medical and academic fraternity, students from UWI, schools of the South St. George East Educational District, and we have some members in our audience, healthcare workers, specially invited guests, our technical and ATSS staff who've helped to put this, this program together, and our opportunities in terms of the wonderful IT support, ladies and gentlemen. As we started to think about what this program should contain, I realized that there was a very strong focus on public health approaches, population health. And I thought maybe it's a good time for us to stop and reflect a little bit about what exactly does alcohol do to cause harm. Because we sometimes are unaware of this. It is such a part of our, and as we've heard from our previous speakers, such a part of our culture that we don't question it. So just to remind you, if you haven't already downloaded our book of abstracts, if you scan the QR code, you will have access to the material for the entire day, and we hope that you will use this as a resource. At the back of the book of abstracts, there are two other documents that you might find interesting. One is a copy, a synopsis of the Global Alcohol Action Plan that was endorsed at the World Health Organization in 2022, and is to provide the framework for the development of alcohol policies at an international level. And the second part is a special focus on alcohol and youth that was part of our Caribbean Alcohol Reduction Day from a couple of years ago, and it's an infographic that you may find useful to disseminate within your schools and environments and institutions. Right, so why do people use alcohol? And I think it's important for us to start with that question. We are here to talk about, well, maybe it's not such a good thing, but it's always important to remind ourselves as to why do people use alcohol. Sometimes it's because of other influential people, including their family members and friends. And one of the studies that we're not presenting today, but did a few years ago, showed that among women who attended rehabilitation centers in Trinidad, one of the key elements was that they were introduced to alcohol at a very early age. They were introduced it at home among their family members, and so it was part and parcel of their everyday existence. And they didn't question why they would use it when they eventually ended up using it. So the influential family members is a critical part of why people become involved with alcohol. We well understand the peer pressure. Marketing plays a big role, and for those of us who we have had a chance to read about the alcohol industry, there's a huge role the alcohol industry plays in the support of alcohol products. For enjoyment, and just before I came up here to do this talk, several other people were talking about the role of dopamine and that pleasure drug, that things that our brains produce when we become happy. And when we have our first drink and our body relaxes and we say, I can dance now, it's because of dopamine, that pleasure compound. So we know that it's been there, it's been around for, the evidence suggests more than 7,000 years people have actively been producing alcohol, and that's the evidence that we are aware of. It may well go beyond that. To relax and to feel calm, to socialize. So a lot of people will tell you, okay, when I have my first drink, now I can party. Before, all the pressures of the world and life has been too stressful. Right? To feel more confident in social situations, to feel happy, to relieve pain, to cope with stress, and to help with sleep. So it's a part of our day-to-day existence. It's been around for thousands of years. It's in the Bible. And if you read it, depending on how you read it, it says that you should be drinking alcohol if you feel sad and depressed. I was recently informed by someone that's not the way to interpret it, but that's the way I will interpret it. So just to remind you that the chronic diseases, accidents and injuries, acute social problems and chronic social problems come about as a result of your patterns of drinking, the volume that you drink, and the patterns will lead to toxic effects, the volume will lead to toxic effects. Then, of course, there's intoxication and there's dependence. We will be hearing later on today about chronic disease in terms of alcohol and hypertension. We will be hearing about accidents and injuries in Trinidad from Professor Sandra Reed. We will be hearing about acute social problems, and we'll be hearing about chronic social problems. So we're trying to cover a lot of the public health aspects in this conference to look at what research has been promoted and created in Trinidad. A little more closer look at how alcohol causes harm. So societal factors, the drinking culture, and we know that in the Caribbean, we have this culture of the rum festivals that Dr. St. John was talking about. Our drinking environment, we have this culture that if there's a wedding, there's the classic trunk opens at the side of the road, whether it's a wedding where alcohol is allowed or accepted or not, right? Our healthcare system plays a role. Is our healthcare system able to respond to the effects of alcohol? Our genetics, we'll be hearing a little bit about the genetic studies that we have in Trinidad. Dr. Shamjit Singh shortly will be telling us about the South Asian research. And later on, Dr. Ryan Kumar from Tobago will be telling us about the research that's been done in the Afro population in Tobago and the harms there. We won't be hearing specifically about gender today, but gender is a huge aspect of it. Women, the recommendations for alcohol consumption in women is always less than men. And that has to do a little bit with your body content of water, the fat content, and the size of the body. We'll be hearing about age. Age is a risk factor for how alcohol impacts. Dr. Leonette Cornette, a consultant gerontologist from San Fernando Hospital, will be telling us today about some of the research that's been carrying on in the country, in the region, about age and alcohol. There's a link between alcohol and poverty. If you're poor, the effect of alcohol use has a greater impact on your family, even though, relatively, people of greater wealth drink more. But the impact of alcohol use on poorer families is greater. And all of these things combine in the volume, patterns, and quality to cause chronic disease and conditions and affect health outcomes, including morbidity and mortality. So this is how it works at the big level. How does it work at the small level? So for those of you, I'll take you back to your chemistry days for a few minutes. Alcohol is called a xenobiotic. That means that your body doesn't naturally produce it. We have found small doses of alcohol in the gastrointestinal tract through the metabolism of bacteria, but primarily when you take alcohol, it's like a foreign substance. Dr. Shamjit Singh will be telling us a little bit about alcohol dehydrogenase, ADH, and ALDH, aldehyde dehydrogenase, a little later on today. But just to let you know that the real critical element here, the real critical compound, is that middle one, acetaldehyde. Acetaldehyde is regarded by the International Agency for Research on Cancer as a group 1 carcinogen. That means, when I say that, you say, well, what does that mean? It means that it's right up there with things like radiation, X-rays. It's right up there with asbestos. And we all know about these. It's right up there with tobacco smoke. So those are the sort of chemicals that we compare alcohol specifically and acetaldehyde, particularly when we think about alcohol and how it does its harms. The length of time that acetaldehyde lasts when you drink in your body is really the critical element. And how these two enzymes, alcohol dehydrogenase and acetaldehyde dehydrogenase, work will sometimes influence how long acetaldehyde behaves or exists in your body. The longer it exists, the more side effects. If you live in East Asia, specifically Japan, China, Korea, large parts of the population experience what we call flushing when they drink. And that flushing is due to the acute accumulation of alcohol. They become very ill. There's nausea, there's vomiting. And these people naturally stay away from alcohol because it's such a terrible effect. And that effect can, in a way, become protective, because if you're now not going to be drinking because of these nasty effects of acetaldehyde, you're actually protected. Unfortunately, because of the metabolism, some of us experience the acetaldehyde but don't get the side effects. And Dr. Singh will be telling us a little bit about that later. These people have become more likely to become addicted but also experience greater harm. And unfortunately, the South Asian population is affected like this. What are the effects of psychoactive alcohol? So a lot of the effects we know about, things like the acute intoxication, but there are also direct toxic effects. There are immunosuppressive effects and teratogenic effects. One of the things that we don't talk about very much in Trinidad is this concept of fetal alcohol spectrum disorder, right? Alcohol use in young women who are of reproductive age is a great risk factor for fetal alcohol spectrum disorder. When you look at the literature, there's an amazing thing that sort of comes true. About 5% of our young women will drink during pregnancy, unknowingly. About 5% of our pregnancies end up with people who have learning disorders. And I've always wondered, is there a link? Maybe one of you young researchers out there will try to find that link for me. I don't know. I wouldn't like to think there's a link, but there may well be. And as physicians, one of the things that we see is how alcohol has a huge interaction with other substances. The outcomes include accidents and injuries, liver disease, liver fibrosis, brain injury, cancer, infections including HIV and hepatitis C, hypertension, stroke, fetal alcohol spectrum disorder, depression, and psychoses, and dependence and addiction. And I'm happy to see some of our psychiatric colleagues here. There are lots of interactions with medicines, and I always recall having one of my patients coming in the day after Carnival and said, I collapsed in the street and I couldn't get up. And he was using cold medication along with his binge drinking on Carnival Tuesday, and totally lost consciousness. He said, I woke up in the drain, not knowing myself. So if you're on any sorts of medications, check it out. Talk to your doctor before you use alcohol. One of the things that doctors have always used, and I'm going to say this, I'll probably run into trouble, is don't use alcohol with antibiotics. Unfortunately, there's only a few antibiotics where that's the case. So not to say that you should drink when you're on antibiotics, but just let you know. We sometimes use this as a little pressure on our patients. Ease up your drinking. So how important is the problem? We've heard a little bit about it already, but you know, we spend a lot of time talking about high blood pressure in medicine. You know, we have lots of medicines. There are about eight antihypertensive drugs on the CDAP, which is free to all Trinidadians, because high blood pressure has been such an integral part of the history of the development of our healthcare systems throughout the region. We've spent a lot of time with tobacco. We have a framework convention on tobacco control that has revolutionized how we address tobacco issues. But alcohol is just a little bit below this, and yet still we're not hearing about alcohol as a major health issue. And so I follow with those speakers who've gone before that says we need to do more of this. And this, hopefully today, we will raise some awareness. Maybe a couple of our young people will say, you know, this is important. Maybe I will try to help to make this a critical regional issue. So the International Agency for Research in Cancer and the U.S. National Toxicology Program, NTP, report on carcinogens talk about a group 1 carcinogen, and I've sort of mentioned this already, so just to highlight again, that there's sufficient evidence of carcinogenicity in humans for these chemicals, and alcohol is one of them. So one of the things that you don't hear about is the link between cancer and alcohol. And this slide, I'll just take a little time and go through it because I think it helps us to understand that link. There are 3 categories. One category is blue, one category is red, and one category is green of drinking. And it's an increase. So you have category 1 is less, category 2 is more, and category 3 is the most. And what you see for mouth and esophageal cancer in the furthest left set of columns, as the intensity of drinking goes up, your risk of developing mouth and esophageal cancer compared to someone who doesn't drink goes up by a matter of 5 times more. Similarly, for esophageal cancer, by 4 times more. For liver cancer, by 3.6 times more. For breast cancer, 1.5 times more. And for diabetes, interestingly, if you drink small amounts of diabetes, there's a chemical called adenoleptin, which actually helps to protect you from the harmful effects of alcohol on diabetes. But as the alcohol content goes up, that is lost. So small amount seems to help. And because of that, we used to have this thing, but isn't a small amount of alcohol good for you? Yes. But the problem is that for certain conditions, you actually get a bit of protection earlier, but not for cancer. Right? If you look at the columns on the left, on my left, your left also, you'll see that they all start at 1.45, 1.8, 1.45. It means that even for small amounts of alcohol, your risk is greater than someone who's not drinking. For diabetes, you see it's 0.92. That means that if you use a small amount of alcohol, you seem to get some early protection against diabetes. But as the intensity of alcohol increases to the green columns, that protection is lost. Okay. Eric, next slide. Okay. Sorry, forgot. Hot off the press. I got this on my computer yesterday. This has not been part of the initial dialogue, and I don't know how well the evidence is going to hold up over time. But this was a study looking at genetics of 118,000 participants in a UK database. And for the first time ever, they're saying that alcohol increases the risk of colorectal cancer. This has not been something that we've talked about before. So here's that famous bit of work that says small amounts of alcohol is good for your heart, right? That's the one we all know. And what you see is that initially the curve is below that relative risk of 1. So that means that compared to people who have no drinking, small amounts of alcohol, less than 20 grams per day, actually seems to protect you from heart disease. But just notice again, as the curve goes up, as your increase goes up to more than 75 grams per day, you start to lose that protection, right? So maybe we all have to have that little discussion. Well, do I want to die from cancer or do I want to die from heart disease? Or maybe, what does my family die from? Maybe I need to look at my family history and decide, what am I happier to go with? And have that internal discussion with ourselves. We need to sometimes do that. That's if you decide to drink. Or you can say, I'm not going to drink, I'm going to take all the other things and protect myself. But I want you to start thinking about it, because I think traditionally in the Caribbean, we haven't been even asking ourselves these things. What is it that's out there? How will we protect ourselves? How do we keep ourselves healthy? So, and then there's, of course, the effect of alcohol use disorder, what we call the AUD. Before, they used to talk about 2 components, alcohol abuse and alcohol dependence, and they've sort of pulled that all together. I'm not going to go through this slide, but just to let you know, there are about 11 criteria, and then there are different stages of intensity. And you can find this on almost any search on the internet. We could always talk about it afterwards if you'd like. But there are lots of things that happen. Some of the things, for example, let's read through a couple of them. Unsuccessful effort to cut down, recurrent use of alcohol in physically hazardous situation, continued use despite having persistent recurrent social or interpersonal problems. So those are the kind of things that we look for to make the diagnosis of alcohol use disorder. And if you have 2 to 3 criteria is defined as mild, 4 to 5 criteria moderate, or greater than 6 severe, right? So this is how the healthcare worker or the psychiatrist will define your alcohol use to make a diagnosis and make a decision about the type of care that might be useful for you. So in conclusion, alcohol is a group 1 carcinogen. Its harm is related to the type, the volume, and the frequency of use. Its harm is associated with your age, your gender, your body size, and your genetics. And its harm includes its intoxicating effects, its direct toxic effects, its dependency, and the interaction with other substances. Right? And as we go through today, we need to keep these things in mind. We'll hear how we're using more than we should, we're using it in situations where we shouldn't be using it, that our genetics is playing a role in how much harm we're getting from it, that it increases our risk of cancer and social harm. And so I'm going to end here. I want to thank you very much for your time and attention, and we're going to pass on to our next speaker, Dr. Ravid Khan. I'm going to say a little bit about Ravid because he's a critical part of the team that we have. Ravid is a lecturer at the Unit of Family Medicine within the Department of Paraclinical Sciences at UWI, and is one of the co-chairs of today's proceedings. Ravid.
Thank you, Professor Rohan Maharaj, Madam Master of Ceremonies, Dr. Stephanie Date, esteemed colleagues, all protocols observed. It's indeed a pleasure for me to be here this morning in commemoration of the Caribbean Alcohol Reduction Day and to partake in the observation and to share my findings. Now, a lot has already been said about the unhealthy use of alcohol by the esteemed speakers that preceded me, but perhaps to provide a context and to provide some country-specific data, I wish to share my presentation with you all this morning as it relates to the findings of the STEP surveys conducted in 13 Caribbean countries over the last couple of decades. And I'll begin the presentation now. So, non-communicable diseases, or NCDs, are responsible for 81% of all deaths in the region of the Americas, of which 34% befall prematurely in people between the ages of 30 to 69 years old. The PAHO WHO stepwise approach to NCD risk factor surveillance, otherwise known as STEPS, is a simple, sequential, standardized method for collecting, analyzing, and disseminating data on key NCD risk factors in countries in adults between the ages of 18 to 69 years old. Alcohol use is recognized as a major contributor to NCDs, including hypertension, stroke, cancer, and liver disease, and is a major contributor to violence, including domestic violence and injury, among peoples of Latin America and the Caribbean region. In 2002, alcohol was responsible for nearly 10% of all disability-adjusted life years, what we call dailies, lost in the Latin American Caribbean region, compared to the global figure of 4.4%. So more than twice the amount of dailies just in the Caribbean alone. Alcohol use is deeply ingrained in our socio-cultural fabric, where heavy episodic drinking is an accepted practice and a common drinking pattern. Residing in the Caribbean region has been shown to be significantly associated with alcohol consumption. And findings from the period 1990 to 2016 reveal that alcohol use remains a significant obstacle towards the achievement of Sustainable Development Goal number 3.5 due to large increases in the per capita alcohol consumption in non-Latin Caribbean. So we conducted basically a search of the databases, PubMed, CINAHL, and Google Scholar, using the keywords alcohol consumption, unhealthy alcohol use, and the Caribbean. 15 papers were identified and the results analyzed. The WHO STEPS reports for the Caribbean territories were also included in analysis. The results are as follows. STEPS data collected during the period 2007 to 2012 from 13 Caribbean countries, namely Barbados, Cayman Islands, Dominica, St. Kitts and Nevis, Trinidad and Tobago, Aruba, Bahamas, Anguilla, St. Vincent, Guyana, St. Lucia, Grenada, and the British Virgin Islands reveal an average prevalence of heavy episodic drinking of 31.5% for males and 14.2% of females, approximating to about 22.9% for both sexes. So just to provide a context here, heavy episodic drinking was defined as engaging in 4 or more drinks on any day in the previous week for females, or 5 or more drinks on any day in the previous week for males. This slide provides some country-specific data relating to the percentage of alcohol consumption among adult males in these 13 Caribbean countries. And what we find here is that males from St. Lucia were the ones that were most likely to engage in heavy episodic drinking. This was closely followed by Aruba and other Caribbean territories such as Grenada and Trinidad and Tobago. In terms of the blue bar there, that speaks to non-drinkers, right, or abstainers. Most of the abstainers here were from the Barbados territory and also from St. Kitts and Nevis. And not surprisingly, the majority of drinkers, people who would have consumed alcohol on at least 4 days within the preceding month, were from the country of St. Lucia. The next slide refers to the findings from the same 13 Caribbean countries, but shows the percentage of alcohol consumption among adults females. And what we found here, Vincentian women were the group most likely to consume the least amount of alcohol. And in terms of lifetime abstainers, the highest percentages exceeding 70% were found in women from Barbados and St. Kitts and Nevis. All right. In terms of women who were most likely to consume unhealthy amounts of alcohol or heavy episodic drinking, we found that women from Aruba were the most likely to engage in heavy episodic drinking, followed by Trinidad and Tobago, St. Kitts and Nevis, and St. Lucia. So, what do these findings suggest? Well, unhealthy alcohol use in the Caribbean region, 22.9%, was higher than the worldwide prevalence of heavy episodic drinking, which averages 18.2%. This data is from the Global Status Report on Alcohol and Health from the year 2018. Unhealthy alcohol use, as I just said, was found to be highest among St. Lucian men, with a prevalence of 49.5%, engaging in heavy episodic drinking, and lowest among Vincentian women, with a prevalence of just 3%. Caribbean males were found to consume more alcohol than women, and were more likely to engage in heavy episodic drinking. This is consistent with the worldwide trend, where men are known to drink considerably more alcohol than women, and more often than women. Caribbean youth also appear to be drinking earlier than in other regions of the world. A study in 2007 found that almost 78% of secondary school students in Trinidad had a first drink before the age of 14 years. And among the countries in the Americas in 2010, 72.9% of male youth in Trinidad and Tobago admitted to heavy episodic drinking, the highest in the region. The Global Student Health Survey reported that in studies between the period 2003 and 2010, that 45% of youth aged 13 to 15 years in the English-speaking Caribbean self-reported alcohol use in the past 30 days. Of more concern was that the report found that 22% of this group reported drinking so much alcohol that they staggered, vomited, or developed slurred speech at least once in their lifetime. A 2010 report found that the average age of first use of alcohol in the Caribbean ranged from as young as 10.9 years to 12.3 years. And this is in fact younger than the average age around the world for the initiation of alcohol use. So, this increase in unhealthy alcohol use in the Caribbean can be attributed to the high availability of alcohol in the region. This point was underscored by one of our previous speakers. Relatively low prices, enhancing accessibility, and extensive promotion and advertising of alcohol beverages being distributed within the Caribbean region. Alcohol consumption is an integral part of the Caribbean culture, which is synonymous with fun and recreation. If we go back to the days of slavery, West Indian slavery and the sugarcane plantation era have influenced the drinking habits of the Caribbean people, of which social drinking is an integral part of embracing our history. So we spoke about rum festivals, carnival, and so on, in which alcohol plays a major part. In terms of deaths and disability, alcohol caused at least 379,000 deaths and over 18 million lost disability-adjusted life years in 2016 alone in the Americas. And alcohol consumption also causes a large social burden to society, as well as an economic burden through costs such as lost productivity, healthcare, police, court, and prisons. Alcohol use hinders sustainable human development across health, economic, social, and environmental areas. And it's really on this background that we form the opinion that unhealthy alcohol use presents an ongoing Caribbean public health problem. The Sustainable Development Goal target of a relative decrease of 10% in the harmful use of alcohol by the year 2030 may not be met if the current trends continue. Therefore, effective policy measures to reduce total alcohol per capita consumption, abbreviated APC, should be put in place as soon as possible to ensure that the impact of alcohol on mortality, morbidity, and development is reduced. These are some of the references from which the data was sought. I thank you for your attention, and please enjoy the rest of today's proceedings. Thank you.
Thank you very much, Ravi. We now go on to our next speaker, who will be Dr. Shamjeet Singh. Dr. Shamjeet Singh, unfortunately, is unable to be here physically, but he is presenting with us from Mount Hope. Shamjeet is a PhD in biochemistry and is currently a lecturer in the School of Pharmacy in the Faculty of Medical Sciences. Shamjeet is going to talk to us about some of the genetic challenges we face in alcohol and some of the findings that link our ethnicity to alcohol metabolism in South Asian population in Trinidad and around the world. Thank you very much, Shamjeet.
Good morning, everyone. 1 second. Yes, good morning, everyone. And let me say what a pleasure it is to be here. Thanks to Professor Maharaj and the organizing committee for giving me the opportunity to present a talk on alcohol and the South Asian. I am presenting on behalf of the colleagues listed here. So the definition of alcohol use disorder and the prevalence and importance of public health has already been discussed. But risk for AUD is actually modulated also by genes and a family history of alcohol problems. Heritability accounts for 45 to 60% of risk in various populations. And of course, as with all genes, genetic predisposition is moderated by the genes environment interplay. But this morning we'll speak a bit about the two main enzymes involved, alcohol dehydrogenase or ADH and aldehyde dehydrogenase or ALDH. As shown before, ethanol is catalyzed by ADH to produce acetaldehyde, which is further catalyzed by ALDH to produce acetate. And this accounts for the majority of the metabolism for alcohol in the human body. But the enzyme CYP2E1, which is a microsomal ethanol oxidizing system, also contributes. There are also non-oxidative pathways catalyzed by fatty acid ethyl ester synthase. And in peroxisome, the enzyme catalase also contributes to metabolism. But these three, they have a minor role generally, but under large amounts of alcohol consumption, they tend to have a greater role. Now, alcohol dehydrogenase is actually coded for by 7 different genes. These genes differ in nucleotide sequences to varying extents. Hence, they are called alleles or variants. And as we know, each person will have 2 alleles from for each gene. So listed here, ADH 1A, 1B, and so forth.
Can I stop you for a second, please?
Sure.
We're seeing it in the mode that for presenter view. Can you put it into full view?
Yeah.
And so the print is very difficult to see. Can you do that?
Oh, sorry. Well, I have it in presentation view here. 1 second.
Right. Yeah. So if you just, that's much better. And if you could just close off the slides on the left-hand side.
Okay. All right. Fine.
Yeah. Thanks. Yeah.
Right. Okay. So this is better. Okay. It went in the presentation view. That's why. No problem. Thanks, Prof. Okay, so essentially these 7 genes, as said, vary slightly in nucleotide sequence. So they are called alleles and alleles.
You can just also click slideshow from currently. Just put it down to the bottom and see if it will come. It keeps going back.
It keeps going back.
I don't know. Okay. Yeah. All right. Just go back to where you were before.
Yeah. Okay.
That one. Yeah.
Yeah. No, I'm not sure why it. Okay. All right. So yeah. So we have variants and alleles of alcohol dehydrogenase. Now the actual enzymes actually shown here in brackets. The actual enzymes are actually homodimers or heterodimers of the various polypeptides produced by these genes. There are 4 of them. Of course, each of them would have different Km and Vmax, different kinetic characteristics. The 4 that actually is dominant in liver and that metabolizes alcohol is shown here in red, the ones that are labeled percentage liver contribution in red. Now, apart from the genetic sequences, the enzymes that are produced, the other level of complexity is that some of these may have mutations, and the mutations actually confer different kinetic characteristics on the resultant enzyme. And we'll see that a bit later on. And also, because these here, the ones that are shown in red, are actually, tend to be expressed normally. And they tend to metabolize most of the alcohol, but it does not mean that certain populations tend to differ in which ones are they expressed. All right, aldehyde dehydrogenase show similar patterns, the main one being ALDH2-1, which actually accounts for most of the metabolism in humans. And there are also polymorphisms that may occur with that particular gene. Now, apart from the metabolism of alcohol to acetaldehyde, which goes in the mitochondria, gets converted to acetate. Acetate leaves, enters circulation and is passed out in urine, or it re-enters general metabolism. Apart from that, there's a few other biochemical aspects that probably we need to be aware of. One is that when that is happening, a lot of NADH is produced, nicotinamide adenine dihydride. I know I'm taking you back to some basic biochemistry here, but bear with me. So NADH actually enters the electron transport chain, is oxidized by the proteins of the electron transport chain in the mitochondria, and that basically uses up a lot of oxygen. So you find that those hepatocytes that are close to arterial circulation tend to draw a lot of oxygen, leaving other parts of the liver hypoxic. Secondly, when that is happening, a lot of reactive oxygen species is actually produced, and what that does is confer a lot of oxidative stress on hepatocytes. Thirdly, NADH actually slows a lot of the general catabolic pathways in all cells, really. So it tends to not efficiently produce energy from carbohydrates and proteins and such through many different pathways. And fourthly, a lot of NADH and a lot of acetate leads to the building blocks and what is needed to produce very low density lipoproteins. So de novo lipogenesis also tends to increase. So these are just 4 of the other effects that take place while large amounts of alcohol is being processed by the liver. Now, all that being said, we know that all that is actually modulated by many different factors: societal factors, social factors, behavioral, and population type factors. And this was eloquently done by Professor Maharaj already. What I want to draw your attention to is the actual changes that can take place with different alleles. So ADH and ALDH alleles are associated, certain ones are associated with AUD. And the general concept that Professor Maharaj already explained, I just want to reiterate, is a fast ADH catalytic activity, that is, or slow ALDH, leaves elevated amounts of acetaldehyde. And this, of course, leads to dizziness, nausea, tachycardia, and so forth. It makes it uncomfortable to drink. It does reduce, it reduces the tolerance to alcohol consumption and can reduce the risk for AUD simply because you drink less. And I just want to draw two examples. There are many examples in the literature, but ADH1B3 is dominant in persons of African descent and Native American tribes in the US. And this increases dramatically the breakdown of alcohol. It leads to buildup of acetaldehyde and has been shown to be protective for AUD. A second example that is shown in Chinese and Japanese individuals is ALDH2 504K. And this just basically means that this is the ALDH2 enzyme, but it has a mutation at the position 504, which basically changes the amino acid from glutamic acid to lysine. So essentially, it is an allele. It's considered an allele, but is actually discovered mutations after these alleles were established in the literature. RS6M1 simply is the number. This is simply the number that the mutation is registered under, and it is called a single nucleotide polymorphism, which is basically a change in one nucleotide that leads to an effect. So 30 to 40% of Chinese and Japanese carry at least one copy of this particular mutation, and that decreases the breakdown of acetaldehyde, And this leads to the classic Asian flushing reaction that is known. And it is also protective for AUD. Interestingly, no, or almost no, different reports say different things, but almost no individuals of European or African descent actually carry this particular allele. Now, with respect to the South Asian, there were 3 studies done right here in the Faculty of Medical Sciences between 2006 to 2008, references 7, 8, and 9. And what these actually showed is that if you were to compare persons of East Indian descent to persons of African descent, and compare them to controls also, you would find that ADH1C2 is associated with alcohol dependence in East Indian, persons of East Indian ancestry. The second study actually showed that African participants with at least one allele had decreased risk for AUD. And the third study actually showed another allele was associated for increased risk with AUD in Indo-Trinidadians. So this basically brought up the conversation in Trinidad about South Asians and their genetic risk or predisposition for developing AUD because of the way alcohol is metabolized. Now, if you were to look in the literature, which we did for studies in South India, per se, you would find different studies show different things. So in South India here, there's a specific genetic variant that predisposes to AUD, and here there are a few variants that basically predisposes to AUD. And all these studies, basically, when we talk about this, it means that they predict for AUD without confounding factors. So they significantly predict for AUD. Okay, there are 2 complications, and I'm not going to go through all the studies here, but there are 2 complications in looking at this type of data. One is that the definition of South Asian is not very clear in the literature. Under medical subject headings, if you go and you look for South Asian, they define South Asian very differently. All right, and the second complication sometimes is that the way these alleles are registered by the IUBMB has changed over the last 15 years. So essentially, they used to use letters, now they use numbers. And sometimes when people register polymorphisms, they use different nomenclature. So this complication is a complication for biochemists like myself to sort, really. And so it takes a bit of doing to actually interpret and to see which ones are actually similar here and different. Now, what has happened over the last 15 years or so, 10 to 15 years, as this audience would know, the advent of a large amounts of genetic data and the skilled application of meta-analyses have been able to, we have been able to analyze many different relationships between populations. And these are just some of the studies listed here that provide very strong evidence for a genetic predisposition. Prevalence studies in the US actually show very significant differences in the risk for AUD between racial and ethnic groups. Genome-wide meta-analysis in people with European ancestry showed 29 risk variants, independent risk variants, and these did include ADH and ALDH. Genome-wide association studies in East Asian persons of East Asian ancestry shows risk variants at ALDH1B and ALDH2. Meta-analyses in comparing various populations, Asian, European, African, and so forth here, interestingly show that individuals with this particular ADH1B2 allele were about half as likely to be alcohol dependent as those without this genetic variant. Right? This meta-analysis here compared other populations, and those with ADH1C1 were about a third as likely to be alcohol dependent. And these are the odds ratio here, which provide very strong evidence that in these populations, these particular expression of these particular alleles do affect the metabolism of alcohol and hence the risk for AUD. Asian samples meta-analysis there too pointed out ALDH2 was associated with was associated with a 4 to 5-fold decrease in alcohol dependence. And two of these alleles, so this is homozygosity, heterozygosity here, this is homozygosity, was associated with an 8 to 9-fold decrease in alcohol dependence. So there's very strong data being developed that shows this particular link. So in conclusion, the expression of specific alleles variants of ADH or ALDH confer protection to AUD, coupled with other mitigating factors, may guide public health approaches to managing AUD. And of course, as with many other chronic type diseases, the genetic architecture of the Caribbean populations is not known. So there's a need to define in Caribbean populations what are the expressed genes and the activity and the ensuing activity of the enzymes. Once again, let me thank Professor Maharaj and the team, and thank you for listening to this short discourse on the biochemical aspects of alcohol metabolism. Thank you.
Thank you very much, So it's telling us that the stories are not clear, and tells us that the information that we have, we need to increase our knowledge to truly understand what's going on. Because some of the initial ones are telling us that particular ethnic groups in our country, based on the genetics, are at higher risk of alcohol use disorders and the harms that ensue. But it isn't 100% clear, and as the Sham has pointed out, we need to do a lot more research in this. Thank you very much, Sham. We may ask you to come back for some questions when we finish, so hopefully be able to be around for us.
Yeah,
I introduce. Yes, Sham.
No, I was just going to say I had an off-time meeting now, but yes, I can be back online to answer questions later when I come back.
Thank you very much. If there's anything, we'll keep that question, and you can come back later on.
Sure. Thank you.
Our next speaker is Dr. Sastry Motilal, who is one of the co-chairs of this conference. Sastry we've been working together at the unit in the Department of Family Medicine and the Department of Paraclinical Sciences for several years together. He is an outstanding clinician with a lot of interest in dermatology, minor surgical procedures. He's a jack of all trades. And he's here today to tell us about one of the studies that we did, a national study on households and alcohol use a few years back. Dr. Motilal.
Okay, good morning all. Thanks for that introduction, Prof. Special hello to our online viewers. All right, so I'm not seeing it on my screen. There we go, thank you. All right, so the National Alcohol Survey of Households in Trinidad and Tobago. I'll be sharing with you some of these findings. This was a national survey done back around 2014. So with the background of this study is a lot of the research on alcohol has actually focused on individual users. People have looked at mental health, they have looked at the physical aspects of alcohol use, behavioral problems, and as we just heard, genetics. We know, and you would have heard some of this data already for the morning, that 84% of adolescents right in our setting in Trinidad have consumed alcohol. Other studies have shown other findings. About a third of our university students actually binge drink. 25% of 13 to 15-year-olds report getting drunk. Our per capita consumption of alcohol is 6.5 liters. And previous studies have shown that heavy drinking occurs in about 20% of the population and 40% of drinkers. So the rationale for this study was that apart from alcohol having effects on individual people, alcohol also affects the household and the family. The household norms, we know, could influence the initiation of alcohol, work and school, and of course, relationships. No formal studies have been done really on alcohol at the household level. Hence, that was the main rationale for doing this nationwide survey almost 10 years ago. And the definition for a household in this study was the person or group of persons who co-reside or occupy a common dwelling. So the methodology used in this study, we selected almost 1,700 households selected from about 50 randomly selected enumeration districts throughout Trinidad and Tobago. We used systematic sampling within each enumeration district that was proportional to the size. And we had a trained interviewer actually go out and speak to the household head or a representative from the household who was an adult, 18 years or older. The instrument we used was a de novo questionnaire that was actually based on the literature. This questionnaire was developed after consultation with family physicians, a psychiatrist, a statistician, public health specialists, and we also cited and looked at other literature in developing this questionnaire. And there were several domains. We looked at the frequency and patterns of current use and viewpoints in the household. We looked at negative experiences over the past year. We looked at the household opinion of alcohol trade and environment. And we looked at tackling alcohol in a national campaign. Most of what I will be presenting will be focused on all the points except point 4, which is the topic actually of another presentation you'll be hearing today. So what did we find? It was an 82% response rates. Almost 2/3 of respondents from a household reported one adult who consumed alcohol. So almost 2/3 of all the households in Trinidad have at least one person that drink. Of these households where one person drinks, half of those households actually report heavy drinking. So in other words, about a third of all the households in Trinidad have a person who drinks heavily. Significant associations arose. So what were the associations for households that do not consume alcohol? Households that reported no consumption were more likely to have a lower monthly income, live in a private house or apartment, and have a household head achieving only a primary school education. So here again, we see the links between alcohol and income, where a higher income is associated with consumption. Significant associations also arose for households that consumed alcohol and the households that report illnesses and calling in sick to work, relationship problems, including infidelity, behavioral and antisocial problems with children, work-related problems, violent behavior, and verbal abuse. When we looked at work-related associations highlighted in white text on the slide, we saw that having a household member calling in sick to work and having a household member suffering a work-related problem was associated with alcohol use, even after adjusting for demographic variables. When we looked at heavy drinking, and again the definition for heavy drinking in this study was 6 drinks or more, when we looked at heavy drinking and socio-demographics, we saw, highlighted in white text, East Indians and mixed ethnicities were more likely to experience heavy drinking compared to African populations. We heard possible reasons for this in the previous speaker, where we saw that certain genetics might be associated with certain ethnicities, be it protective or harmful. We also saw that upper middle income and high income was more likely to report heavy drinking. And also university and tertiary level education was associated with a higher chance of heavy drinking. When we looked at household experiences within the past year, we saw that there were certain positive correlations, meaning if there was heavy drinking, it was more likely to occur. Having a lifestyle-related illness, a major illness, having relationship problems, having strained relationships within the household, infidelity, behavioral problems, and receiving a traffic ticket was all associated with heavy drinking. In terms of certain viewpoints, we sought to measure the viewpoints of households with respect to alcohol. Most of the associations shown on the slide were positive. Alcohol consumption is a normal part of this household daily life. Alcohol consumption at family gatherings is a normal occurrence. In this household, drinking alcohol is considered a pleasurable activity. In this household, alcohol is consumed in the presence of children. And in this household, alcohol is a reward for a hard day's work. Agreement with these statements were all positively correlated with heavy alcohol use. Continuing along the viewpoints, taking a drink together helps ease household tensions. Sometimes a personal or household problem are resolved over a drink. Drinking together enables the household members to cope with the pressures of life. In this household, young people are allowed to drink alcohol in preparation for adult life. Again, these viewpoints were more present in households where there was heavy drinking. So what does all of this mean? It means alcohol use and binge drinking is actually common, and the related associations are significant right here in Trinidad and Tobago. Viewpoints of alcohol is that it is something that's routine, pleasurable, and it's done in the presence of children. This represents opportunities for education and culture change. Heavy drinking is common, half of consuming households. Low alcohol consumption may incur cardiovascular benefit, as we heard this morning, but such benefits are lost when alcohol is heavy, and we just heard that actually even low amounts of alcohol may not be protective. It might actually be harmful for other diseases, mainly, as we heard this morning, cancer. Heavy drinking affects overall health, executive functioning, and increases the risk of stroke and total mortality. So what are the recommendations? We'll be hearing about some of these throughout the rest of today, but in terms of what can we do, we could look at policies to influence sale availability and taxes. We could do policies at the level of family, community, school-based, mass media, and we could actually look at workplace and illicit sale of interventions. And these recommendations are actually ranked based on an overview of systematic reviews in terms of the strength, what really works. And this actually leads into what we'll probably hear later on today, the best buys, what we could do to limit the harmful effects of alcohol at a national level. So what were the strengths of the study? It was a nationally representative sample. It was the first survey to look at alcohol effects in Trinidad at the level of the household, and to also look at the patterns of alcohol use. We found several key associations between alcohol use and heavy drinking and certain household experiences. Again, there were certain limitations. The interviewee who we selected may not have spoken on behalf accurately of the entire household. There may have been underreporting of alcohol use and negative experiences, making our associations probably less than what it actually may be. But we found associations, and this was a cross-sectional study. So associations doesn't always equal cause, so you have to be careful how we interpret these associations. And this study looked at the household. We did not aim to measure AUD at an individual level or abuse or other drugs. So with that, I thank you, and I also like to say that this study would not have been possible without the support of a few key players. One, the University of the West Indies, the Campus Committee for Research and Publication, they funded this study. Also, we received support from ECHORN. And this study would not have been possible without the Central Statistical Office and the enumerators, these people who actually went out to all these randomly selected enumeration districts, going household to household, begging people to answer a survey. It would not have been possible without them. They did lots of hard work, and they were excellent. If it weren't for them, we would not have been able to get a nationally representative sample. So with that, I thank you.
Are we ready, Eric? Yes? So we have now a short video. Unfortunately, our next presenter is unable to be here. They in the middle of a very critical rotation in medical school, and the team begged that, listen, we really can't take time off, you know, even though they did a lot of hard work in getting this paper done. So what I did is I summarized their work and put it in a little video. You'll forgive me if the quality isn't up to, you know, the standards. I had a very short amount of time to do it, so we're gonna listen to some of the results. What we did in this study was look at 40 years of research on adolescent and alcohol use in the Caribbean. So we went back to 1980. They worked very hard. They scoured the literature and came up with the papers and then summarized it in this report. It hasn't been published yet, so you're hearing this probably for the first time. Unfortunately, they're not here to do a full justice, so I'm just going to give you a brief flavor of what was found. Eric? Yes.
(59.5%). Factors that contributed to alcohol use in this population include family relationships, low self-esteem, and peer pressure. Outcomes of alcohol consumption. 2 full-text articles reported the outcome of alcohol consumption among adolescents. First, university students were involved in unplanned sexual activity, and secondly, past-year alcohol users were more likely to engage in risky sexual behaviors. The risk factors for lifetime use of alcohol by adolescents include 1. Lifetime use of cannabis. 2. Increased parental drinking habits. 3. Greater accessibility to drugs, including alcohol. The protective factors identified for lifetime use, past month use and past year use of alcohol include 1. Parents sometimes knowing the whereabouts of the students. 2. Having a mother who drinks every day. 3. Students who had meals with their parents daily. 4. Increased parental involvement with the adolescent. 5. Improved relationship with mother or father. A report on the burden of selected alcohol-related diseases among the age group 15 to 19 years in the English-speaking Caribbean countries for the years 2000, 2009, and 2019 revealed that the disability-adjusted life years and years of life loss has on average remained the same in the 2 decades. In summary, The prevalence of alcohol use reported in the 1980s and 1990s was higher than during 2000 to 2010. However, in 2010 to 2020, the prevalence was still high, with the highest lifetime prevalence of alcohol being 94%, alcohol use in the past year being 76.4%, and alcohol use among adolescents in the past month being 52.2%. Conclusion: over the past 40 years, despite global and regional goals, there has not been a change in alcohol use and binge drinking among adolescents and youth in the English-speaking Caribbean.
So, I want to thank Rick from ClipChimp. For those of you who know the software from Microsoft, this was a quick attempt to sort of summarize that work since we didn't have our students here with us. But thank you very much, Rick, for a great job. So, in summary, the research is suggesting to us that despite a lot of our regional expectations of improvement, a lot of our policies saying that we want to reduce adolescent use by a certain amount, this has not happened. And the takeaway message is really we need to get our act together and trying to work on this issue. It takes me great pleasure to introduce Leanne. I didn't see you there for a moment. I said, where's Leanne? Dr. Leanne Cornett, who is a consultant physician from San Fernando. She's driven up here. Thank you so much for coming. And Mr. Bowen, thank you so much for making it today. Leanne's going to talk to us about her special areas, which is gerontology and the role of alcohol in the elderly, and specifically looking at two studies that's come out of the region, one from Jamaica and one from the Eastern Caribbean, that sort of summarizes what we know about this population and alcohol. Leanne, thank you. Welcome.
Good morning, everyone. So it's indeed a pleasure to talk today about alcohol in the older populations in the Caribbean. Why? Because people worldwide are living longer. So much so that today, most people can expect to live into their 60s and beyond. Every country in the world is experiencing growth in both the size and proportion of older persons in their population. So in the year 2020, there were 1 billion persons throughout the world aged 60 years and above. And guess what? By 2030, which is 7 years from now, this number will increase from 1 billion persons to 1.4 billion persons. And then guess what? By 2050, so if you look at the chart next, you will see the dark blue areas being highlighted even more. By 2050, this number will double, so there'll be 2.1 billion persons throughout the world over the age of 60 years. And this is not just happening in first world countries. Let's come down to the Caribbean. The population in the Caribbean here is like that of the rest of the world. The younger societies are basically giving way to communities where older persons form a larger proportion of the population. So in the Caribbean, at the turn of the millennium, there were about 10% of the population over the age of 60. So if you look at this chart here, look at the light blue area. Guess what happened by the time we reach 2050? Look at the dark blue area. The dark blue bars are almost twice the length of the light blue bars. So by 2050, about 26% of the Caribbean population will be over the age of 60 years. So the aging population is a direct product of what we call a demographic transition. Now, when we hear aging population, we think about what happens at a biological level. So the process of aging is associated with a gradual physiologic change. So we see changes that increase the risk of a person developing a disease. So we hear about changes in their heart, changes in their heart rate, changes in their blood pressure, changes in something called their cardiac output, changes in their lungs. What about alcohol? Because the topic here today is alcohol in the older population. Do you think alcohol has an effect on the older population? It does. What is this alcohol we speak about? So alcohol is basically one of the most widely used encountered drugs in the world. And its beverages are a complex mixture of chemicals, of which ethanol is the #1 ingredient. And it is credited with both positive and negative side effects. And as Prof and other colleagues mentioned before, alcohol is a non-communicable disease risk factor. What is the effect of alcohol with age? Well, alcohol metabolism changes with advance in age because of decreased activities of certain enzymes. We heard earlier today about alcohol dehydrogenase. We heard about acetaldehyde dehydrogenase. We heard about the cytochrome P450 system. The decreased enzymatic changes occur with age, as well as decreased water of distribution and slower rates of elimination, all basically leading to increased blood concentration of alcohol. What else happens as you age? Older persons may take more drugs. And what happens is ethanol and these drugs may interact. So therefore, alcohol consumption can modify serum drug concentrations and their toxicities. So what we're basically saying is that as one ages, there's a change in metabolism, there's a change in distribution, there's a change in elimination, and increased risk of drug-to-drug interaction when dealing with alcohol. Now, alcohol does not only affect the liver. These effects are seen throughout the body, in the central nervous system, cardiovascular system, gastrointestinal system, in the immune system. Due to the decreased ability to distribute, or because of its ability to distribute in all bodily surfaces, we have changes in all the cells throughout the body. What is a direct effect or an indirect effect? Now, the etiology of this, there are some postulations. There's a role to play of inflammatory enzymes, and there's a role to play of dysregulation of cytokines. And guess what? There are several studies throughout the world that talk about a relationship between alcohol and all-cause mortality, not just in the older population, but even in the middle-aged population and the general population. Now, this study here is basically the population-based Gothenburg age 70 is a birth cohort study. It includes over 1,124 individuals. And what they found was that hazardous drinking was associated with an increased risk of all-cause mortality in populations over the age of 70 years. And what they also found was that persons who consumed alcohol, who had at least 5 lifestyle risk factors, whether they have decreased BMI or elevated BMI, whether they smoked or their dietary pattern did not adhere to the Mediterranean diet, these persons also had an increased risk of all-cause mortality. So therefore, we may wonder, is there evidence of alcohol consumption among the older adults? We've heard presentations before about adults in general. We've heard about adolescents, but what about the older adults? The answer is yes. As one of my colleagues mentioned, we spoke about the STEPS program, or the STEPS risk factor survey. So it's basically a nationally representative cross-sectional survey conducted from January to June in 2013 on the prevalence of non-communicable diseases risk factors using the WHO STEPS instrument in Trinidad and Tobago. So when they look at STEPS, what did they find? Look at the table we've seen in front of us. We found that if we look at the age group 55 to 64, you'll see now it's highlighted in yellow, 55 to 64 years, we see 516 of these persons involved in alcohol consumption. And of these 516 persons, guess what? 330 of them were females. Just under about 180 were males. And then 1/3 of them, which is 34.5 according to the chart we have here, 1/3 of them were current alcohol drinkers. In other words, they drank alcohol within the last 30 days. About 15% of them drank alcohol within the last 12 months, but not within the last 30 days. This is significant. And we just heard from Dr. Sastry about the National Alcohol Survey of Households, which has further proved that alcohol consumption occurs in at least 60% of the households in Trinidad and Tobago. What about Jamaica? Let's move up the islands now. In Jamaica, a research from the United Nations in 2016 found that alcohol was most widely used drug in Jamaica, accounting for 40% of the entire population. And just as in Trinidad and Tobago, alcohol is a major risk factor for non-communicable diseases. So in this study by Oshie et al., they looked at basically 4,600 participants. 316 of them were older populations, so that's 6.8%. And the prevalence of lifetime alcohol drinking was almost 75%. Those who drank alcohol significantly within the last year, this was statistically significantly associated with gender, their marital status, and religion. Those who drank alcohol within the last month, this was associated with religious affiliation. This is statistical significance. In a multivariate logic module, the odds of the past year drinking among males was 4.3 times higher as in females. And the currently married older person had a 62% decreased odds of drinking alcohol within the last year. And let's spend some time looking at this study called an ECHORN cohort study. Now, this is a first of its kind regional research network that basically generates action-oriented research on chronic diseases. So ECHORN stands for Eastern Caribbean Health Outcomes Research Network. And it followed up 3,000 adults in Puerto Rico, U.S. Virgin Islands, Barbados, as well as Trinidad and Tobago. And they basically followed up these persons over time, looked at their risk factors and protective factors for the development of chronic diseases. So out of these 3,000 persons, guess what? At least 1/3 of them were over the age of 60 years. We're talking about the older population right now. And of these 1,032 persons, 1/3 of them were males, which means about 2/3 of them were females. And over 2/3 of these patients gave a history of ever drinking. And what is the definition of ever drinking? It basically means that 2/3 of these persons said they drank at least one drink at any time in their life. That's ever drinking. Let's look at the chart again. 1/5 of these persons were current drinkers. And how did we know that? In this ECHORN study, they use a single item with a binary yes or no response. Are you a current drinker? Yes? 21.8% of the persons said yes. This is the older population we're talking about. Then there's a category of problem drinker. Who are the problem drinkers? We use a KH questionnaire, CAGE, the KH questionnaire, and anybody who got at least 2 points out of the 4 points, they were considered problem drinkers. And 5% of these persons were classified as problem drinkers. And then look at the last category, the heavy drinkers. The heavy drinkers are based on the National Institute on Alcohol Abuse and Alcoholism definition for binge drinking. So this is similar to what Dr. Sastry mentioned just now. So a binge drinker, according to this definition, or heavy drinker, is basically a male who consumes at least 5 drinks in one sitting, or a female who consumes at least 4 drinks in one sitting. So they found that 6.5% of the person fit into this category as heavy drinkers or binge drinkers. They even took this group and subdivided them into the frequency in which they binge drink, as in 1 to 2 days or at least 3 days. Now, what are the characteristics of these over 60 persons in this ECHORN study? Well, 46% of them said their ethnicity was black. About 20% had Caribbean ethnicity. 1/3 were employed. And almost 40% of them did not attend high school. So that's primary school. That's similar to what Dr. Sastry mentioned in his research just now. 41% said they were married. And 1/5 of them were either separated or divorced or widowed. This is the one. Look at this first one. We're looking at chronic diseases. More than half of those persons over the age of 60 years either had stage 1 or stage 2 hypertension. 1/3 of them had diabetes mellitus. 8% had cancer. And 13% of them were depressed. More than half these 60-year-olds had low physical activity, and 1/4 of them slept for at least 8 hours a night. 1/3 had at least 5 sexual partners. We took this cohort of 60 people, over 60-year-old persons, and we divide them into the ever drinkers, current drinkers, problem drinkers, and the binge drinkers, or the heavy drinkers. What I have in a box here are what was statistically significant. So there is an association with ever drinking and gender. 1/3 were female. Marital status, 40% were married. Religion, 26% were Protestants. 23% were Catholics. 40% of them said they were highly spiritual. 46% of them said they had low activity. Some had cancer. 1/3 had at least 5 sexual partners. That's the ever drinkers. What about the heavy drinkers? There was a statistical association with, again, ethnicity, marital status, religion, spirituality. 1/3 of them said they were very spiritual or moderately spiritual. And guess what? Cancer. And 50% had at least stage 1 hypertension. So therefore, from this we see, just give me 1 second to move the slide. From this we see a few things. Alcohol is used amongst the older adults in the English-speaking Caribbean. We have the TNT STEP survey. We have the Trinidad and Tobago household survey. We have the surveys done in Jamaica looking at alcohol consumption among the elderly persons. We have the ECHORN study done in 4 islands, USVI, Puerto Rico, Trinidad and Tobago, and Barbados. We find that the drinking profiles of these older persons were varied. If you look at the ECHORN study, more than 2/3 give a history of ever drinking, at least 1 drink throughout their lifestyle. 1/5 were current drinkers. 5% were problem drinkers. 6.5% were heavy drinkers or binge drinkers. And guess what? There are health consequences of this, which can be either direct or indirect, and it can even be associated with all-cause mortality. The significant associations, our takeaway points, that stage 1 hypertension was more likely to be reported in the heavy drinkers. Those who reported ever drinking, so they drank at least once in their lifestyle, were more likely to report a cancer. This is statistical significance. In the Jamaica study, those who drank over the past month, this was significantly associated with religious affiliation. Those who drank within the last year were statistically associated with gender, marital status, and religion. This only means that further studies are needed. Thank you very much.
Okay, so we're coming close to the end of our first session, and we have a recording from Dr. Ryan Kumar, who's going to talk to us about a study that was done in Tobago. It's a very unique study. This is where they followed a large population of Tobagonians for 30 years. If you think about that, most of us live in a community. We don't even live in a community for 30 years, but these researchers followed these people for 30 years and tried to understand what predicted whether or not you lived or died, right? So it's a very, very powerful study. These are called cohorts, and they're very powerful and very unique studies in medicine. So Ryan is a graduate of our family medicine program. He's got his DM in family medicine last year, and he's been working in Tobago for, I think, most of his life, and he's been a house officer there for about 15 years. And we are about to see his presentation. Eric? Yeah.
Thanks, Prof. I will share my screen.
Okay, thank you very much, Ryan, and thank you. Welcome, and please proceed. I'd just like to, just one thing for the audience, if you have any questions, please jot it down, and we're going around, we'll have a few minutes for questions and answer after this presentation.
All right, Prof, am I in presenter mode or are you seeing my full slides?
We are seeing your full slide, yes, go ahead.
Okay, great. So good day, everyone. All protocols observed. My name is Ryan Kumar. I'm indeed honored to present this research study done over in Tobago. It was published in January 2011 at the 2023 conference on the harmful effects of alcohol use in the English-speaking Caribbean. The study authored by Molokai Nitch, our own Dr. Alan Patrick, and McKaig, is entitled The 30-Year Patterns of Mortality in Tobago, 1976 to 2005. The main objective was to determine chief predictors of all-cause mortality and cardiovascular mortality in the population of Plymouth. Plymouth is a small village on the northwest coast of Tobago over a 30-year span. Plymouth was chosen because the population was thought to be representative of the population on the island. The researchers had easy access to the village. The village has low migration rates, and the residents would have shown a willingness to participate. So the study employed a questionnaire survey for cardiovascular risk factors and alcohol consumption patterns, which was administered in 1976, and set up a fantastic baseline data with a 92.5% response rate. And they were able to follow up 831 out of 832 patients, either until the passing or 2005. Follow-up entailed visits to participants' homes, interviews with doctors and family members, and also checks made at the local death registry. Now, I know tables can sometimes be a little bit difficult to see on slides. Let me put on this pointer. Okay. So this table shows the baseline means and prevalence of risk factors by sex, men and women. As with tables, so just to highlight, though alcohol intake was common in both men and women, 85% in men, 70% in women, the total consumed by men was significantly more than women, 11.3 units per week as compared to 2.5 units per week. And over 23% of men here had a high sessional intake recorded as more than 6 units in a given session, compared to only 2% of women. Men, 5.7% of men scored higher than 2 on the CAGE score, compared to only 0.2% of women, 0.2%. So this is just a summary of what we discussed. This table was presented because researchers found evidence that all-cause mortality with several risk factors varied by age group. Hence, they went on to analyze the data stratified into those under 60 and those over 60. So this follows nicely from the previous presentation where we were discussing alcohol use also in persons elderly. All right. Table 3 shows predictors of all-cause mortality, looking at single risk factor associations, stratified again by age, under 60 and over 60, at baseline. So in the under 60 age group at baseline, predictors of all-cause mortality in the single risk factor analysis were BMI, higher BMIs, higher sessional intake of alcohol, alcohol dependence as having a CAGE score greater than 2, the presence of hypertension or left ventricular strain, and either having impaired glucose tolerance or diabetes. This again summarizes. So again, looking at all-cause mortality, the subsequent analysis using the multivariate analysis on all-cause mortality by age group is shown here on table 4. There was a prominent effect of increasing years of age from baseline in both groups. You have significance here in age increasing in the under 60 and also age increasing in the over 60. Male sex was also a major predictor of all-cause mortality for ages over 60, as well as an increased cardiothoracic ratio. In those under 60, BMI, hypertension, and diabetes showed significance in predictors of risk. So we're switching now to look at the breakdown of predictors of cardiovascular mortality, specifically here in table 5. And we're looking particularly again at the single risk factor associations that the researchers found. In persons in this age, in this group, in persons aged less than 60 years, predictors were BMI, high alcohol intake, high sessional alcohol intake, Kh greater than 2, hypertension and left ventricular strain, and glucose intolerance. In those coming over here, in those over 60, while this followed a similar pattern, predictors were also male sex, BMI, alcohol dependence, hypertension, and the enlarged cardiothoracic ratio. All right, table 6, again, which shows association with cardiovascular mortality using multivariate analysis. Older age was a major risk factor for both the under and over 60 groups. So here again, the increasing age, while also being male and over 60, showed increased risk. Strikingly, over here in the under 60 age group, I just wanted to show hypertension almost tripled cardiovascular risk. And having left ventricular strain, high sessional alcohol intake, and diabetes significantly increased risk from dying from a cardiovascular cause. So it was found that excessive sessional alcohol consumption was 10 times higher in men when compared to women, and this had explained 40% of cardiovascular deaths of men less than 60 years of age. Because high sessional alcohol consumption is very rare in women, the major risk factor in women is impaired glucose tolerance or diabetes, which explain 28% of deaths in women, again, aged less than 60 years. So studies in Tobago have identified alcohol as a possible risk factor for cardiovascular disease, attributable to direct effects of alcohol on the heart, but also through effects on blood pressure. This study, we believe, has merit in part because of the long follow-up period used, as well as the high retention rate of the participants. Traditionally, in the Afro-Caribbean population, we have been aware of hypertension and left ventricular strain as risk factors for mortality. And this study clearly makes a case that alcohol is a major contributor. I want to thank you very much.
Thank you very much, Ryan, for summarizing this really important bit of work for us. So, ladies and gentlemen, we're coming close to our first break. I want to open the floor for any questions, comments. I think that we also have possible comments from our participants online. Just to let you know, currently there are 80 participants from around the Caribbean and outside of the Caribbean following the conference at this point in time. So I think we need to. I want to just really support our friends from ATC, Stephanie, and some of the people also behind the scenes, Danielle, Doriel, and Maisha, for really making a difference to make sure that we reach out to our regional partners. Do we have any questions on the floor? We'd ask you please to use the microphone so that people online can hear what your question is. Yeah, Stephanie?
Hi, morning again. So my question was actually for Dr. Kumar. I saw that the study was done in Tobago, but I'm interested to know if you have any plans on expanding that to Trinidad or anywhere else in the region.
So maybe I can answer that. Technically, that's what ECHORN's about. Hopefully, we will be able, as we go through the second iteration of the ECHORN cohort, we should be able to get some of that same type of studies. Not 30 years, but at the current rate, and given what has happened with COVID, we may go on to certainly a decade and a half. But as far as I know, the work is not continuing in Tobago in this particular study. But Ryan, do you know anything else that's been happening in that population?
Professor Maharaj, actually, I previously had a little bit of interest in HIV research here in Tobago, but after having been brought into this conference today and having read the papers, I think that there's the need actually for continuation of this kind of research, particularly to add to the national body of work.
So if you're in Tobago and Plymouth has a very low migratory rate, maybe it's time for you to think for looking for some funding and doing some follow-up. I think that was done by the University of Pittsburgh. Maybe you need to talk to them.
Yes, Prof. Actually, this exercise has brought up a lot of those issues. I think I want to talk to you about it more.
There you go. We started the first project from the conference. Any questions on the floor? I see some questions, some comments in the chat. Doriel, have you picked up on any particular questions from our online audience that you'd like to bring to the presenters?
Yes.
In the
Can you
meantime,
hear me?
okay. Yes. Okay, Doriel. Would you go ahead?
Great. We have a question from Joanne, and I believe this is for Dr. Leanne Cognac-Bowen. She asks, were the types of drink among the elderly highlighted / specified? Was it on a social basis or for home remedy? Brandy seems to be one of the common alcohol drinks used in that group with the belief of possible medicinal benefit.
That's really interesting. I'll see this. My mom has passed away now, but every now and again, I see the brandy bottle would go down. She'd use it for all sorts of ailments. But it is a common thing. Do you have a response?
I'm not sure. I know the question for current alcohol drinking. It was a question. It was a yes or no question. So one of the themes for ECHORN was to look also at the psychosocial aspects. So the etiology of the drinking or the reasons for the drinking is something that's also going to be looked into.
Okay. So just to let you know, when we talk about alcohol, we talk about primarily about three types: beer, wine, and spirits. For a beer, we're talking about an average one bottle of beer is considered to be one standard drink. For wine, usually a glass of 250 mLs, and for spirits, one ounce of a shot, basically what you call a shot glass. That's considered one. Now, the reason we talk about binge drinking as being dangerous is that when you have these 4 to 5 drinks within a very short period of time, that's when the blood alcohol concentration rises to the level that makes it dangerous for you to drive and interact. And that's why those sort of cutoff points are used. I saw a couple of hands on the table here. Dr. Bass.
Thank you. Dr. Cognac-Bowen, this is for you. I know there's some studies with the Bajan population and their aging. There are some populations there that age really well and they're 90 years and above. Is there any evidence in these geriatric population of an association with that increasing age or longevity and alcohol use and also the way in which alcohol is used?
So Barbados was included in the ECHORN study, which is good. So it's Barbados, Trinidad and Tobago, Puerto Rico, and U.S. Virgin Islands. So the fact that Barbados was included is good, but that's the evidence we have, the cumulative evidence from the ECHORN study. What ECHORN did, besides giving us the characteristics of the over 60, they further subdivided that subset. So we have the ever drinkers in that subset, the current drinkers, the abstainers, the binge drinkers, or the heavy drinkers in that subset. So I think when we continue with the ECHORN study, as Prof was talking about, we will get a bigger idea of what's going on in the Caribbean, in these 4 islands, because what ECHORN is doing is that it's following up these 3,000 participants over time. So it's good to see the effect now and the effect later on. Remember, with the older adults, the CNS effects especially can cause geriatric symptoms, falls, and with falls you get increased risk of fractures, hospitalization, institutionalization, functional status being decreased. So it's good for us to look at this population so we can recognize if there are any complications and geriatric syndromes that can arise from a complication of alcohol drinking.
Yeah. So there is some real good opportunity coming up, and we look forward to this, to Wave 2. We almost the 2/3 done with Wave 2 on the ECHORN project, and that analysis certainly for me and alcohol and how it impacts on our older population, given the Tobago study, would be really important. Dr. Tayo? Yeah. Good morning.
Morning. My question is about the short film. I'm not sure I saw correctly, but there was this segment on protective factors for adolescents, and it seemed as if I saw something about the maternal use of alcohol being a protective factor. I wanted to clarify, did Rick make a mistake, or was this something that...
This was actually something that they saw. I don't know if they quite explained exactly what, but I suspect it may have to do with, you know, many people, when they see someone very close to them drinking, they themselves don't drink. And I think because the motherly role is so important for the well-being of a child, they see their mother drinking, I suspect that makes them really against themselves being involved with alcohol. I haven't gone to that literature for a while, but I think it's worthwhile going back to the original papers and trying to find that answer for you. And I have the original text. We'll go back to it and try to find that answer for you. Doriel, do we have any other questions for our online audience?
Yes, we have 2 more. So we have a question from Jacqueline. Please restate what is the definition of ever drinkers in the ECHORN report?
So this was very simple. Have you ever had a drink? So it usually means that have you ever experimented? Have you had one? Could have been that you had one at a very early age. It's a very open statement about exposure to alcohol.
Okay, and the second question.
Answers the question.
Yes, thank you. Has any study looked at the correlation between alcohol drinking and mental illness?
So we will be presenting almost our last study today is going to be looking at anxiety and depression among university students. So yes, there have been many studies on this. What we do know, maybe I can ask our psychiatrist friends to talk about this. Dr. Tayo, do you want to have a quick answer for us, or should I just go with what I know from the literature? Go with literature, yeah. So there is a very strong association between mental illness, particularly around depression and anxiety with alcohol. And there's another part of it is that about 25% of suicides are linked to alcohol use, whether or not it makes it easier for the suicidal attempt to occur, or whether or not it contributed through the depression aspect of it on the individual. We know that there is a link, so yes. Okay, I'm going to give you guys a little time to go have a little washroom break, have some water, have a little coffee or some tea, and we come back. We try to start back at 10:45, which is now. But I know we're still doing pretty good for time, and I want to compliment our speakers. Thank you very much to everyone who's participated and contributed so far. And I'm sure that when we get a little break, then I think some of the questions will be coming to the different presenters. Thank you very much for your time, and we meet you back. Let's say we will start back at 11 o'clock. Okay, thank you very much.
This is just a call for persons to return to your seats as we prepare for the next session in this exciting conference today. So just call to your seats as you're having your non-alcoholic beverages provided at the conference here this morning. All right, so I'm noticing some much rested, smiling faces. I assume that the conversations going around are very enticing, enlightening. It's always good to connect with our colleagues and different sectors in the society at large. So we're moving along with this morning's conference. You would have heard from our esteemed speakers before on the national policies and some of the national issues in terms of studies that are population-based. So we looked at population-based studies and literature there. So this next section is actually going to be now more broadening our perspective from a regional base and a regional policy. And, you know, we're listening to the regional anthem that we started with there. And it really speaks to, as a Caribbean, how much we have to look at things as a group and as a unified entity to bring our English-speaking Caribbean especially together. So our next presentation actually is someone who is very familiar again to us here. And I implore each one of you all to look at the program that has been available through the QR code. You'll find detailed descriptions and of each one of our presenters here this morning. So inviting once more to the podium is our esteemed Professor Rohan Maharaj, and he has worked at the St. Augustine campus here at the University of the West Indies since the year 2000 in family medicine. And since 2015, he has been the Alcohol Policy Advisor to the Healthy Caribbean Coalition, the HCC. And this morning, he'll be presenting on the alcohol policy in the English-speaking Caribbean. I invite Prof. to the stage.
Thank you again. Eric, can we see slides? Okay. So I had a wonderful discussion at our little break in which someone said to me, how do we move forward? What do we do next? And what the evidence suggests to us is that one of the things that we can do quickly that is cost-effective and is very often acceptable to the population is policy. What's a policy? Right? A policy is a law, a regulation, a recommendation that's made to a population on a particular topic that can make a difference to the health or the well-being of your population. And I forget again, right? But before I start, you know, we've been talking about populations. We'll be talking about policy. I want to bring it back first for a little while to people that we see, our patients, our friends, and our family. And this was a story I heard in the space of 1 week. I saw two totally different patients. One was a wife, and one was a brother of people who were using alcohol very heavily. And they both said in almost the same words, when he drinks, it's like a different person, a beast. I become anxious, awaiting the blows that may come at any time. And it's just to help us to humanize the data. We're hearing all these percentages and all these things. But this is something that is real, that affects our patients, our friends, our family, our neighbors in a very serious way. And so when we think about trying to make a difference to this is the sort of things that we're trying to also help. Okay. So we've mentioned already that alcohol is probably the third most important risk factor for global disease, right? And in Caribbean society, we've heard about the links to our economic health, right? But it's tied in to all the factors, how we as a Caribbean people developed, right? The origins of indentureship and slavery, the culture that we have, our sports, right? We still see a lot of our sporting bodies and institutions being supported by alcohol. And for those of you who watch the World Cup, you will see across a green band with a red star, and everybody knows what that means. I think that you already know what that means, right? You know what it means. I'm not going to call the name. If you want to know, you'll meet me at the side of the room afterwards. I'm not going to advertise for anybody, right? But on top of that, a lot of our sources of national and regional pride, Angostura, Bacardi, right? Guyanese rum, world class, Mongué, right? 300 years. 300 years, the oldest rum distillery in the world. So we have, it's a source of regional and national pride, right? And tied into that, the whole idea of the Caribbean as a destination for sun, fun, and other things. The commerce, advertising, employment, and industry that's generated from alcohol. And in the middle, we have the government trying to play the role of getting taxes, getting legislation and employment, and enforcing this legislation and employment. But we have other forces that act also on us. Globalization and places like the World Trade Organization that, because of the rules that they have enforced, have told us that we have to behave around alcohol in a particular way. The thing about alcohol is the alcohol industry sneaked in very early, and the alcohol is traded like rice and flour and sugar. But it's an addictive and carcinogenic substance. How come that we do that? And that's because the knowledge about these properties are really only now becoming available. It was only in 2007 that the IARC that I mentioned before released their documentation that says this is a group 1 carcinogen. So it's a relatively late understanding. And it's tied into things like development. If we have a small population like ours, when you lose people through alcohol, these are people that you're losing who are our human resources, right? And it's tied into things like human rights. When I speak to people from the alcohol industry, they say, well, what about the right of people enjoyment, the right to have fun, right? And they will support that. But we are saying that there's another side, a darker side. And for those of us who work in public health, we think about the social effects. Those of us who see patients with domestic violence, we see a lot of people being, when you look at our murder rate, you see a lot of people dying in rum shops. I don't know if you've noticed that. But is there a link? Is it the fact that people are drinking and they become disinhibited and they report, people go home for the cutlass and come back. They are so drunk, they feel so infuriated by whatever has happened, and they lose the ability to really adjust and deal with things at a different level. And this is all then is that we have this constant balance, the benefits versus the harms. And unfortunately, we have a lot of our governments saying, well, we need to support the economic well-being of our region, right? And if we tackle alcohol in a serious way, we may lose our image, we may lose our tourism, right? Yeah. And someone that we love and admire on the world stage also has another side that says she needs to support the economy, right? So when we think about changing behavior, for those of us in public health, we can think of a worldwide approach, a workplace approach, and a family individual approach. And we saw that very much during the COVID epidemic, right? And this is where we get the whole idea of policy, right? So we can have a global or national policy, we can have local regulations, or we can have even things that we say we will tackle at a medical level. So policy is this idea that if we can do things at a big level, it can affect the entire population, right? So a public health policy is defined as laws, regulations, actions, and decisions implemented within society in order to promote wellness and ensure that specific health goals are met. These policies can range from formal legislation to community outreach efforts and include things like healthcare, insurance, education, agriculture, and business, right? One of the more successful models for improving the healthcare with regards to things like alcohol and drugs is what goes on in Iceland. And I recommend to everyone who's interested in this, look up how Iceland has tackled some of these issues and kinds of things that they've put into place to protect their young people especially. Right. So given this background, a few years ago, we started to think about what is happening in our region. What are the current alcohol policies within the region, and how does it relate to what's recommended by the World Health Organization? And the World Health Organization has a couple of things specifically, one called best buys and one called good buys. And if we can identify what those policies are, then where are the gaps and the opportunities for those of us who work in civil society to have a role? So we reviewed the documents that we had from WHO, and they had the global status reports, and the two in particular we were able to access, the 2014 and 2018 global status report. I also communicated with people around the Caribbean, and then we used the WHO best buys as a sort of template to do the analysis of the policies. Right? So the best buy is, by definition, an intervention that is not only highly cost-effective, but also cheap, feasible, and culturally acceptable to implement. And the WHO says that the best buys, for example, for chronic disease, are these 10 things. But the really important ones are the ones with the double asterisks. If we can address, for example, for alcohol, the availability of alcohol, the marketing of alcohol, and the policies around alcohol, then it seems that those would be very quick, very easy to implement, would need some political will, yes, but they will be very cost effective to implement. The other things, health services response, how you fix your healthcare service to respond to people with alcohol issues, drink driving countermeasures and drink driving policies, and we know we have some of those things in place already. And then reducing the negative consequences of drinking and alcohol intoxication. So how you, for example, deal with things like how you sell alcohol at the bar level, how you educate salespeople about when to allow people to drink to what level and so on. So what were the results when we did the analysis of the region? We found that almost all countries had some sort of legislation around alcohol. But many of times it's in legislation not directly dealing with health, but with a social and economic focus. There are a few national policies, but the interesting thing is even though the WHO recognizes that these policies are present, when I speak to people, they don't know. So for example, there is one that's supposed to be present in the Bahamas. I don't know if Stanley knows about it, but when I speak to my doctor friends in the Bahamas, they say, what policy are you talking about? So it's a well-kept secret. Right? It's also, you see the policies in conjunction to non-communicable diseases and with mental health policies, and sometimes when it's linked to illegal substance use. Right? So there are lots of regulations in Trinidad dealing with alcohol, and similarly we can see that in a paper that we're trying to publish right now. We've also looked at it in Jamaica and Barbados. So there's regulations around advertisements, about brewing, criminal offenses, the Customs and Excises Acts, liquor licenses, the Motor Vehicle and Road Traffic Act, spirits and spirit compound, which is what is alcohol, what is a spirit, and the Licensing Act that comes out of the UK. So many of these things are not dealing with alcohol specifically, but around alcohol as, not in health, but around alcohol as an object of commerce. Throughout the region, so we were able to get information on 11 countries. I think it's 11, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12 countries. And these were the sort of policies. So the ones that we have here on the left, we asked the question, is there a written national policy that's been adopted and revised? So we see there the country, the only one country that's in green says yes, that's the Bahamas. There's also one that's been in discussion in Trinidad and one that's been in discussion in Jamaica, but they haven't been ratified and agreed upon, right? So generally we have maybe about 80% across the region saying that there's no policy. However, most of the governments give some sort of support for community action. So that green on the second line says that only one country, the government says, well, we're not really interested in that, St. Vincent and the Grenadines, but the rest of the country says, this is important. Do countries have some way of monitoring what's going on? And we see about half of the countries on the third line, third row, saying, yes, we have a monitoring system. And I suspect that much of this monitoring is going on through the Caribbean Public Health Agency. So this is national policies taxes, blood alcohol concentrations. And we continue with those. So almost all the countries, because of the commerce aspect, have excise taxes. Excise taxes mean that the government collects money from the local production of alcohol. So it's not like it's imported, but like Angostura will pay the government for producing alcohol in Trinidad. And this is a substantial amount of income for government. So all of the governments in the region recognize this as a source. So they don't want to rock the boat because, you know, you're getting money from these people. And so you don't want to say, well, you got to pay more. And most countries on the second row here on this slide have some sort of national maximum legal blood alcohol concentration for driving. When it comes to who can drink in terms of the age, we see that about most countries have some sort of regulations. But you see here, Antigua and Barbuda, their laws say that a 10-year-old can buy alcohol. Right? That's what it still says according to the reports from PAHO. And that's because of these smaller countries, the culture is, well, my grandson can go down the road and buy something for me. And I remember being small and people are, you know, saying, go and buy something for me in the rum shop. They do like grandmothers here, you know. And that's the kind of culture that we've grown up with. But the information is changing and we need to change with it, right? There's a national minimum laid, so there's on-premise purchase and on-premise consumption and off-premises. So many countries you can buy, but you can't drink on-site. And that's what the first row is. And the second row is for on-premise sales and consumption. And you see that there's some restrictions in some of them, but not all. So we do about 50% on this one across the region. Right? When you go to the rum shops in Trinidad, you see the sign, open any day, any time. Right? And so we're not doing too well on this throughout the Caribbean. There are not very many restrictions on this. So there's some, but it's not uniform and it's not well established. Availability is one of the big best buys under the WHO. What basically availability does is when you have lots of places selling alcohol, what happens? It drives the price down. When the price goes down, it makes it more affordable, and you very often see upsurge in activity that's detrimental to individuals. So a lot of places are starting to say, well, we need to address this. And you can do it through either reducing the density of outlets or reducing or insisting that there's a minimum unit price for alcohol, as happened, for example, recently in Scotland. But where we're doing the worst and where everything is red is in advertising, marketing, and labeling. Right? So we have basically, there are no restrictions on alcohol labeling or marketing in the region. And only, like I said, only the Bahamas had something, but when we asked them about it, they're not aware. So it's not really enforced and being monitored. When we take all of these together and we put a number value, we're coming in at around 47–50% across the region. So out of all the things that we can do, we're only halfway there. And so there's a big role for us as countries, as populations, to make a difference, and civil society also can make a difference. So how do we move forward? There's some opportunities for us to look at a comprehensive regional policy on alcohol to address things like marketing and advertisement. A couple countries are linking alcohol price to things like inflation, because what happens is over time, because of inflation, prices fundamentally become less. So Scotland has recently, after a lot of battle with the alcohol industry, were able to introduce a minimum unit pricing. What that means is no more happy hour, right? Because a happy hour means 2 for the price of 1, right? All alcohol is sold at a standard price. What that does is it makes alcohol a much more conscious decision. It becomes a little bit more expensive, but our data in the Caribbean started with Professor Rohan, who was one of our first professors of psychiatry in the region, showed that when alcohol prices goes up, you get reduction in the harm associated with it, right? Some countries are looking at the idea of labeling. And when you label, what it does is it makes certain populations more aware of the harm. One of those populations, a young woman of reproductive age, when they're able to see the information in front of them, they often make decisions that are healthier for themselves. And I think come 2026 in Ireland, every alcohol product will be labeled by law about the harms. And so other countries that you usually associate with scotch and whiskey and so on, are making hard decisions for their population. How come we are not doing the same? That's all I can ask, right? Right, so on a final thought, there's clear gaps in our policy around alcohol, but the intertwining of culture, economic interests, political lethargy, and public acceptance make change difficult, but not impossible. And in fact, Dr. Barber is going to be presenting what we found when we asked households, are you willing to accept change, right? There are clear opportunities for civil society to advocate for new policy, strengthen old ones, and prepare our societies for change. I think that's it. Thank you very much.
Thank you very much, Professor. And again, reminder to jot your questions down. I think this section particularly is going to be a very enticing question and answer section. So save your questions for those online as well for after. Next up, we have someone, again, who is very dear to this venture and this conference. Dr. Stephanie Date is a former consultant for the HCC CARD 2019 and 2022. And is in the process of submitting her PhD in pharmacology thesis, which is a focus in uterine cancer. So she's here this morning going to talk about the alcohol policy on a survey of regional stakeholders. Please welcome Dr. Stephanie Date.
Well, I hope I'm enticing. No pressure. So thank you once again. So today I'm going to be presenting this survey, but when I say we, I'm referring to the HCC because I was consulting with them when we actually hosted this, the card, and also released the survey. So every year, as we know, we have a CARD, the Caribbean Alcohol Reduction Day. And proud to say we've now completed 8 of them. You're sitting in the 8th one. In 2022, the theme of CARD was the WHO Global Alcohol Action Plan, specifically priorities and implications for the Caribbean. The theme was actually chosen to recognize the endorsement of the WHO Global Alcohol Action Plan, and part of this HCC initiative, we chose that plan because of this. I think Dr. Giraldo was who mentioned SAFER earlier, but from this Global Alcohol Action Plan came these 6 major action areas. They were created to essentially effectively implement this overall global alcohol action plan. Now, I think some medical students might be out there. When I was a medical student, I loved acronyms. They saved my life. They got me to graduate. So this is an acronym. It was a WHO initiative called SAFER. The WHO Secretariat and partners developed this technical package to essentially help out governments to implement major alcohol policies that were outlined in the plan. So essentially, we have this big global alcohol action plan, we have a SAFER technical package, and we now have these major areas that we need to focus on. We need to prioritize these major 6 areas in order to actually implement this plan. But what HCC wanted to know is, okay, we have this SAFER technical package, we have these priorities, but what are the regional alcohol policy priorities? Let's ask people in the Caribbean region, what will your priorities be? What do we need to focus on? And also, from a civil society perspective, what are some barriers that we think are going to pop up against these alcohol policies in specifically our region? So here's just a little snapshot of our survey, and we gave out this survey electronically. So we distributed it. It's a 10-question survey to both local and regional stakeholders. So we sent it out possibly to some of you. I hope some of you saw this. If not, you will have another chance to look at it. But it included our ministries of health, our substance abuse councils, and of course, members of the HCC. So we really wanted to know what are our regional alcohol policy priorities. We based it specifically on these 6 action areas, and under each of these letters, we have different action points and different priority areas that we wanted to know and to rank in the region. So this is a little bit small, but essentially we had 37 people complete the survey. We only released it for about 2 to 3 months, and members of the HCC, Caribbean private sector, some private physicians filled it out, people who were healthcare providers in the region, and even some non-HCC members as well filled it out. So, the major question was, we want you to rank on a scale of 1 to 5 which policies outlined in the safer technical package below, so in the question, do you believe are the highest priority areas for HCC and our members to advocate for? So what are the major priority areas? How will you rank this? So under S in the safer technical package, S stands for strengthening restrictions on alcohol availability. So I'm going to pose this question to you now as the audience. We have these 5 different subsets that fall under the strengthening restrictions on alcohol availability. We asked in the survey, how will you rank this? So I'm going to ask you, if you could only choose one of these as your highest priority area, which one would it be? Would you want to regulate hours and days where alcohol is being sold? Do you want to implement licensing systems? Do you want to restrict use of alcohol in public? Or do you want to establish a national legal minimum age? Any guesses? What would you choose? All 5, unfortunately. We have to choose just one. Anyone for number 1? Good, okay, a couple number 1s. How about number 2? Okay, a couple for licensing. Who would regulate the number, density, and location? All right, so too many rum shops. I think we're all in agreement of that one. Okay, so believe it or not, the one that was ranked the highest was the national legal minimum age for purchasing and consuming alcohol. So we heard it earlier, I think it was in Antigua, a 10-year-old can walk into an establishment and get a drink. I don't know if I'm the only one in here, but have any of you gone to a restaurant or a bar with a group of people who happen to be drinking alcohol, and have you placed an order for a non-alcoholic beverage? If you haven't, I think you should try it, because you literally get looked at like you're absolutely crazy. For women, we literally get looked at and they look straight to our stomach to say, oh, I don't know her uterus, no, she's not pregnant, she's just crazy, okay? It's very, very difficult for youth especially, for adolescents, people who are very easily influenced, to say no. And sometimes you're offered a cigarette and you say no, and people tend to accept that. Alcohol is a drug. Alcohol is a carcinogen. So why, when I am saying no, is it not good enough for waiters or friends? It's very difficult at my age even to say, no guys, I'm good, let alone a child or an adolescent. So this was number 1 priority from people who took our survey. The next one, advancing and enforcing drink driving countermeasures. Now, we were supposed to be getting a breathalyzer in Barbados. Hasn't yet happened, but I was always very impressed when any of my Trinidadian family members came to Barbados, because we would head out, you know, we're going out to dinner, assuming some people might be having some drinks, and they would look at me and say, but who's driving? I say, what do you mean? Me. And that was unheard of. We don't really have that in Barbados. You can literally go to a fete, you can drink as much as you want, you can get in a car and you can drive home, if you make it home. So we asked this question about advancing and enforcing countermeasures with people who are drinking and driving. How about this one? Do you want to make it mandatory for drivers to be educated? Should you prioritize counseling and treatment programs for repeat offenders, so people who might continuously get DUIs? Or do you want to establish restricting blood alcohol concentration limits? Do you want to lower the limit? So believe it or not, the number 1 was actually number 5. So this is ranked from bottom going up as the most to the least important priorities that people chose. So they believed that establishing and restricting the blood alcohol concentration was the most important priority to them. And as we move on, we also looked at facilitating access to screening, brief interventions, and treatment. And these are ranked from most important or most prioritized to least. So people who took the survey said that they think the most important one is to increase the capacity of health and social welfare systems in order to deliver these prevention and treatment care for people with alcohol use disorders. That was the one that they chose. We think that's very, very important in the region. So during CARD, we created these different infographics because essentially we wanted to be able to go to governments and say, listen, this is facts, this is data, these are our priorities, let's have a call for action, let's implement these things and get a successful global alcohol action plan. So almost done here, we're enforcing bans or comprehensive restrictions on alcohol advertising, sponsorship, and promotions. So about 4 years ago in Barbados, I launched an initiative called the Pink Drink Campaign. And I am one of the council members at our local cancer society. And essentially what that program is, it's to get restaurants on board. And they're supposed to choose a pink drink. And they promote it during the month of October and raise funds for breast cancer and spread breast cancer awareness. But the number one catch is that the drinks cannot contain alcohol. We raised almost $20,000 the first year we did it, which was fantastic. But the really amazing thing is that most people who were ordering these pink drinks, they automatically said, wait, what? Where's the rum? What do you mean? And I had little infographics just stating the percentages and the risk increase if you have one drink. And it was amazing how much money we raised because people still opted to get these non-alcoholic drinks, which was fantastic. But why pink? Because we market towards women. Mom, you've had a long day at work. Mom needs her glass of wine. Let's make this drink pink, girly, pretty. When that drink lands on the table, ladies, what do? We pull out our phone and we take a picture of it and we share it. And everyone says, ooh, where's that from? I want one. So believe it or not, when you take a step back and you realize how much this is happening, you realize how much the youth and women especially are being marketed towards. Yes? So just something to really think about. And the last one we looked at was what would the priority area be for raising prices on alcohol through excise taxes. Taxes is a bad word in Barbados, but the number one priority was to reduce or stop subsidies to economic operators in the area of alcohol. The second you read that, you go, good luck with that. Right? Because so many people rely on the alcohol industry and so many countries rely on the industry to stay afloat. But that was the number one area in this particular subset. So the last thing I'm going to look at is just, the last question was, what do you believe is going to be the biggest barrier in the region? Now that we have these priorities, what's the biggest barrier that might prevent these alcohol policies from actually being implemented? So I want you guys just to yell out some things to me. What do you think is a barrier to us actually getting this done? Politics. Rohan, how did you know? Excellent. What else? Yes, government, economical, very good. So lack of education was one of them. That's going to be a big barrier. Government's fear of losing votes, we just heard about. Rum production as a major economic driver. Absolutely. And this was a big one, because we're not talking about the United States, we're talking about cultural influence. Rum drinkers don't get sick. Does anyone recognize that? It's a lyric to one of the most recent soca songs in Barbados. The song literally surrounds the fact that people who drink rum won't get sick. And I'm sure I could sit here and I could list thousands of soca songs that are surrounding the use of alcohol. It's in our culture, it's in our blood, literally. Yes, it's a cultural norm. Every street corner is a rum shop. The cunning nature of underage drinkers was one of the statements as well. And again, it's cool. You need to say yes. If you don't say yes, you're not cool. So these were recognized as some of the biggest barriers. And of course, the influence on the livelihood of different households. So I'm going to leave this with you. What will your priorities be? Thank you so much.
Thank you very much, Dr. Stephanie Deet, for such an engaging discussion. I think you can see the reaction from everyone here in the physical audience as well as those online, that these are things that are really personal, and we can all relate to this, especially here in the Caribbean. So we're really moving along this conference with these policy, and all of us here, I want you all to be thinking about how can we come up with some ideas here today in moving this forward as a region. So up next, we have looking at this Caribbean Alcohol Reduction Day, the acronym CARD, and what has happened over the first 7 years. And it's my pleasure to introduce Dr. Kenneth Connell. Dr. Connell received his undergraduate and postgraduate training in medicine from the University of the West Indies. He joined the Faculty of Medical Sciences as a lecturer in clinical pharmacology and is currently Deputy Dean for Phase 1 at the Cave campus. Please welcome Dr. Kenneth Connell.
So thank you very much, Chair, and let me just confirm that you can hear me. Okay, I'm assuming that you can. Okay, well, this has been for lack of a better word, an interesting academic cocktail for me.
Yeah, just bear with us 1 second as we confirm that Dr. Connell is there. And, you know, just following up with the presentations already there, we really can think about how much, especially the marketing aspects of alcohol in the Caribbean has become so normalized that everywhere you turn, there's these things in your face on social media, on television, on mass media, you're driving. It really is something that is tremendous. So we're just confirming that Dr. Connell is there with us.
So I think the online audience is hearing me.
To, you know, we probably may jump to your presentation. So I think we're going to go ahead with that in the interim. So Dr. Terence Babwa is no stranger to us here in Trinidad and Tobago and the region. He's a graduate of the DM program in family medicine at St. Augustine, the University of the West Indies, and has also obtained his master's in science in sport medicine. He's a past lecturer at the Faculty of Medical Sciences and past team doctor for the Trinidad and Tobago football team at the 2006 World Cup. So Dr. Babwa will be looking at the same household study, part 2, the willingness of the households to support changes in these policies, laws, and regulations. So it's my great honor to invite to you all Dr. Terence Babwa. Yeah.
The National Alcohol Survey of Households in Trinidad and Tobago, NASHT. Researchers, households' willingness to support Maharaj, changes in policies, Babwa, laws and regulations. Paula Nunes, Rachel Brathwaite, George Legal, and Sandra Reed. Alcohol presents an ongoing Caribbean public health problem. 45% of youth aged 13 to 15 years in the English-speaking Caribbean self-reported alcohol use in the past 30 days. Among adults 15 to 64 years old, in Trinidad and Tobago, 40.4% consumed alcohol in the past 30 days, 50.6% males and 30. Among the countries in the Americas in 2010, 72.9% of male youth in T&T admit to high episodic drinking, the highest in the region. In T&T, noncommunicable diseases, NCDs, account for 80% of overall mortality. Alcohol use is recognized as a major contributor to NCDs including hypertension, stroke, cancer, and liver disease. It is a major contributor to violence, including domestic violence, and injury among peoples of Latin America and the Caribbean. Alcohol can be sold by many establishments in Trinidad and Tobago, for example, on an any day, anytime basis, and many petrol stations also sell alcohol. Many politicians are involved in protecting the local and regional alcohol production and trade against global interests. An aim of the NASH was to determine the changes to alcohol-related laws, regulations, advertisements and other policies that would be acceptable to households in Trinidad and Tobago. And what proportion of households would be willing to support these changes. We also wanted to determine whether there were significant differences in support between households where alcohol was consumed versus those where it was not. And households where there was heavy episodic drinking versus those where there was none? Methodology. Cross-sectional design. Convenience sampling. A de novo questionnaire was created based on an extensive literature review and consultation with experts. Interviewers were experienced Central Statistical Office workers. Our results. 53 enumeration districts accounting for 1.8% of national EDs were surveyed. Of 1,837 households approached, 1,695 responded, response rate 92%. In 81.5% of the households, the head of the household was the main respondent. In total, the 1,695 households represented 5,525 adults, 2,734 men and 2,791 women, and 1,553 persons under 18 years. Households reported the predominant ethnicity as African, 41.4%, East Indian, 29.4%, and mixed, 28.1%. What would your household support in a national campaign? Drinking age. In a national campaign, over 80% of households would support setting the legal age for drinking at 21 years and advocating for proof of age to be shown by persons purchasing alcohol. Almost 80% would support holding the seller responsible for alcohol sales. Breathalyzer. 9 out of 10 respondents would support stricter enforcement of the breathalyzer, and an increased public education campaign. Advertising. The majority, 50 to 73%, of households supported changes in the advertising and delinking advertising with social success. And banning songs on the radio that have a reference to alcohol use. The nature of advertising. 62.7% of households would support a campaign to delink consumption of alcohol with social success and sex. 69.4% of households would support a campaign to delink consumption of alcohol with driving and physical performance. Retail sales, and more than 75% of households would support a national campaign holding sellers of alcohol responsible for the amount of alcohol sold to a particular person. Age of consumers. Advocating that proof of age to be shown by persons buying alcohol, placing more prominent warning labels on products displaying alcohol content. Placing more prominent warning labels on products showing harmful effects. Density of alcohol outlets. 87.1% of households reported having more than one outlet for retail alcohol sales within walking distance of their residence, 1 to 2 kilometers, and 31.9% reported having more than 3. The density of bars. 10% of households reported being annoyed by the number of bars in their neighborhood. 15% wished to see fewer bars in their neighborhood, and 8% were disturbed by noise from bar. In a national campaign, 37.6% of households would support reducing the opening hours of bars and rum shops. Taxation. In a national campaign, over 80% of households would support increasing taxes on alcohol sales. We compared households where alcohol is used and those where alcohol is not used for their willingness to support national campaigns. Heavy episodic drinking, HED, within households and the supportive policy. Significant differences occurred, however, with less support among HH with HED for the following policy changes: stricter and more intensive enforcement of breathalyzer. More prominent warning labels on products displaying the alcohol concentration and reduced opening hours were desired. Households would like to see fewer bars operating in their community. Households were disturbed by the noise coming from bars, or were disturbed by the patrons coming from the bars. The survey had a large sample size and a high response rate. This is due to the experience of the interviewers. This suggests the population is receptive to the dissemination of information pertaining to alcohol and to the implementation of regulations and policies that have been demonstrated to be a success. Limitations.
So, you know, coming out of the pandemic, there's so many negative, but one of the positive things I think is the way in which we conduct these conferences and the ability to do these hybrid conferences. So, but thanks once again to Dr. Terence Barbour for putting it there. And these policies really speak to me from my personal experience. And, you know, when you look at these rum shops in a local setting here in Trinidad and Tobago, they're very densely populated in these rural communities, and these policies you can see would have a lasting impact in reducing these the negative effects of alcohol. So we go straight across now to Dr. Kenneth Connell, who is joining us online to present on the first 7 years on this Caribbean Alcohol Reduction Day. So Dr. Connell.
Thank you very much, Chair. Can you hear me now? Yes, because I can hear an echo. So let me just say I'm very much glad, I'm proud to be here as part of this meeting. I'm a bit disappointed not to be in what I consider my second home. But I do have 3 observations I want to share with you before starting my presentation. The first one is Rohan remembered Beijing rum as Mokge, but he forgot the name of El Dorado, the Guyanese rum. And I know another professor of family medicine was online. The second point is, you know, as a medical student at a campus that is well known for carnival, I remember distinctly in one of the pharmacology lectures where we were discussing the P450 system and its induction with alcohol, and I'm a clinical pharmacologist, that one of my classmates was justifying chronic alcohol consumption just to keep the P450 levels high. So it just shows you that even at that early stage, healthcare professionals, even though we should know better, we justify it using science, that alcohol, a little bit of alcohol chronically is actually good for you. And the third thing is, this is quite acutely, this morning I am on take, which is why I'm not joining you in Trinidad. But the first admission so far to the team was actually a guy presenting in heart failure with what is called a dilated cardiomyopathy. And I immediately said to the team, because I know the patient and his history, it was related to chronic alcohol use, that we should code it as an alcohol-related admission. And that conference really signaled that change for me. So I'm going to go ahead and get started now on my presentation. And hopefully you can see it shortly. You should be seeing it now. Great. So I'm presenting on behalf of the Caribbean, the Healthy Caribbean Coalition as Vice President. And let me start by saying the HCC, in collaboration with regional partners, launched the annual Caribbean Alcohol Reduction Day, or CARD, in 2016. The aim of CARD is really to sensitize people of the Caribbean, including the public and policymakers, so all of society and all of governance, to the harmful effects of alcohol consumption, and also to promote the implementation of evidence-based and informed alcohol control policies. And we've seen some of them that Dr. Date has presented so well, including the safer policy. So CARD has been implemented now for annually, for 8 years. It is even now can be acclaimed as COVID resistant because it continued during the COVID-19 pandemic. The first year was 2016, as I said, and this started with HCC's Alcohol Reduction Day. The misuse of alcohol is a bigger problem than you think, trying to drive awareness that alcohol isn't just a relaxation method or a cultural identity, but really trying to get people to rally around the cry to live better and reduce alcohol consumption. HCC is committed to advocating for the introduction of a regional comprehensive policy on alcohol and supporting civil society organizations as we do at the country level to advocate for national comprehensive policies for the reduction of the harmful use of alcohol. And some of the priority areas identified back in 2016 was the marketing of alcoholic beverages, so comprehensive bans on alcohol marketing, particularly to children and adolescents. This is something I'm extremely passionate about, and I would extend that up to university students as well, where I think a lot of alcohol debuts occur in university. You don't have the heavy regulation from your parents being around. There's a lot of peer pressure. You're in a strange environment or a foreign environment in many cases, and you want to fit in. And this is where I think experimentation with alcohol can occur. So even targeting university students. Pricing policies increases in taxation on alcohol beverages and earmark revenue for taxes for NCD prevention and control programs. Even sitting on our own National NCD Commission, when we speak about the taxation or the so-called sin taxes, I often remind commissioners that where is this revenue being used? Is it really being used for NCD prevention? And of course, our policymakers and governments don't like to earmark these funds. But really, that is also a WHO recommendation. They are earmarked for NCD prevention and control programs. And finally, awareness of political commitment, raise awareness of public and CSOs about the magnitude of alcohol-related problems. Quite often, I follow a lot of our politicians around the regional space when they speak out about NCDs. And I hear them speaking about several risk factors for non-communicable diseases, such as physical activity. Some of them even participate visually and exercise for the public to see. Healthy foods and availability of affordable and seasonal healthy foods, as well as other measures such as knowing your numbers and blood pressure and also blood glucose control, I don't see many of them speaking out against alcohol. I don't see many of them coming out and saying alcohol reduction. I especially don't see it around carnivals or crop over festivals. And I just wonder whether our Caribbean leaders are doing as much as they can to speak out and to identify alcohol as an NCD risk factor. So the second year was 2017. The theme, drink less, reduce cancer. Many of you in the room may be healthcare professionals. Some of you may even be medical practitioners. This is something I have a real difficulty in drilling down on in the patients sitting in front of me when I tell them that no alcohol is safe. And I often use the cancer risk to exemplify that. Some patients look at me in disbelief. Others look at me with, well, I guess I'll have to take the chance because I'm not going to give up alcohol. But this is really something I don't think as a medical fraternity we have driven home to the public sufficiently. Alcohol is carcinogenic. It causes cancer. Ethanol, which is the main component of alcoholic beverages, is actually carcinogenic. How many of you were asked the last time you visited your doctor for anything, maybe a COVID-19 vaccine? Are you aware that alcohol is carcinogenic? Not many of us. It's a difficult conversation for us, especially when the retort from patients usually is, well, my grandfather had as much alcohol and he lived to whatever. And also, alcohol is part of our cultural identity, and identity is important for us as Caribbean citizens. These are some of the things that you hear. So it's an uphill battle. I mentioned university students, and I know for sure that when I was at university, I'm sure things hasn't changed that much, although they probably have. You know, young people engage a lot in drinking activities simply to fit in. You're in a foreign country, there's a national carnival. Besides wearing a costume and staying out late at night, part of that whole experience involves alcohol. And if you don't drink alcohol, as Dr. Date said, you're looked on, male or female, as if something must be wrong with you. Eventually, you drink some alcohol, it now becomes part of the fit-in mentality, and you continue drinking. I don't think that we focus enough on these young people as they're building skills. Interestingly, I had a conversation with a group of medical students who alerted me that they do discuss alcohol a lot. And I am told that there are now these things called mocktails, which is really non-alcoholic cocktails. And it's quite popular with young people. And that I think is encouraging because it suggests that a behavioral change is certainly occurring. And it's now cool to go out and not drink. I certainly would not have been brave enough to mention a mocktail in my class when I was at university. So I'm glad to see this has changed. So we need to target youth more, and these infographics speak to that, talking to kids at home, talking to kids at schools, and also our high-risk groups, the university, I think, speaking to them as medical students and healthcare professionals when they're most at risk. In 2019, we had the 4th Caribbean Cards Conference, and it looked at alcohol specifically in gender-based violence and alcohol in women. And this, again, is something that we don't even question as much in consultations. When people admit to drinking or when we quantify that they're drinking excessively, besides getting them to reduce alcohol consumption or to stop, how many of us as healthcare workers inquire about how alcohol consumption is influencing gender-based violence? These are things that unless we flag them, unless we action them, will continue to be unrecognized. And then in 2019, the pandemic came. And of course, people were on lockdown and in isolation. I know Trinidad, for instance, you were on an extended lockdown period. And of course, being in isolation, what do you do to pass the time? You probably consume some alcohol. I remember when the restrictions were placed in Barbados, the number one concern, it seemed, early in the pandemic was the sale of alcohol was paused temporarily, and people were in a panic. I have one colleague who said to me, his priority right now is to get to any supermarket to stock up, because he's not sure how long this lockdown would be. And also stock up on alcohol. So we are people who are meant to be the key people out there fighting the fight against alcohol consumption. And yet, in an emergency, the priority becomes still alcohol. So each year, alcohol consumption contributes to about 3 million deaths globally, 390,000 in the Americas, and 18.9 million disability-adjusted life years. And of course, alcohol weakens the immune system, and this is why it was initially suggested or reported or advised that it caused increased susceptibility to COVID-19. But of course, in isolation, we saw monthly consumption of informal or illicit alcohol use increased during the pandemic, and heavy episodic drinking among young people also increased significantly. So that change occurred. And also, what would be an interesting metric would be to look at how much of this increased drinking during the COVID-19 pandemic actually continued post-pandemic, even in our young people. Were there, for instance, people who never drank before, but because of the environment and the additional mental health stressors, how many of them started to drink during the pandemic and continued? Dr. Date has already mentioned the 6th Caribbean Reduction Day, and this looks at challenges and opportunities in the Caribbean. This is a WHO statement. And CARD 2017, looking at the WHO Global Alcohol Reduction Plan 2022 to 2030, which this is really a menu, a non-alcoholic menu, looking at policies that can be implemented. These are things that regional commissions such as NCD commissions should look carefully at as we plan to address this at a policy level, at a national and regional level. And here we are for the 8th CARD meeting, which is currently in progress. So I know I'm out of time, but so just to summarize some of the key successes and lessons learned, CARD has become recognized as a major day in the annual calendar. I think that's important, the fact that we are all here to recognize and interrogate the evidentiary basis for some of the recommendations made. Alcohol reduction says a lot as a region. CARD has evolved and grown to be supported by major regional public health institutions and national governments, including departments responsible for substance abuse and civil society organizations. But despite growing support, it remains one of the most challenging of the risk factors, with the protest of performance when tracking NCD policy implementation. Civil society engagement around this is also weak. We have obviously prioritized other things as civil society organizations. Greater investment all around is needed, both at a government level and civil society, to support the momentum in this area. Research, as we've heard a lot of it this morning, is a promising area to expand the local evidence base to drive policy action. I want to close with some points which are not on my slide, and these are points that we may wish to consider during today's meeting. How do we, as a healthcare professional, how do we dissociate health risk versus culture in the Caribbean context? And who are the key experts that we need to engage? For instance, the cultural practitioners. From a pedagogical standpoint, how will the institutions like the University of the West Indies engage the Faculty of Culture, Creative and Performing Arts or social scientists in addressing this at a population level? And increase political buy-in. How do we get political champions to bravely speak out about the harmful use of alcohol, as they do for other things like physical inactivity and, of course, the sugar-sweetened beverage taxation? We need a comprehensive regional policy. And as an educator, I'm going to close by saying, how do we change our own teaching of future healthcare professionals on alcohol reduction and its risks, to see things not in the context of just what we did, and I'm sure I'm guilty of this, Dr. Date can probably attest to that, just really talking about a caged questionnaire to medical students. How do we change their whole view of alcohol and its impact on the Caribbean society, and not just the patient that presents in heart failure in the emergency room? If we can address these things, then we are on the road to success. But first, political buy-in will be significantly needed, and this is something I think that needs to be urgently addressed. Thank you very much. Enjoy the rest of your conference and enjoy the mocktails that may be present there. Thank you.
Thank you very much, Dr. Cornell, joining us live from Barbados. So we go quickly into our Q&A session for 4 presenters on the regional policy. So Dr. Cornell, if you can just stick around for a few minutes as well to online if any questions come your way. So in the live audience here, any questions for presenters? And we'll make some checks online as well. Are there any questions online? Yeah. Yeah, so we'll move right along to our next segment. So we do have a question. No? Sure. So it's my pleasure to introduce my good colleague, Dr. Leanne Conyett-Bowen, who will be facilitating this next session. Let's give a round of applause for Dr. Conyett.
Thank you, Dr. Basdale. I'm excited to chair this session on the social impact of alcohol, because we know alcohol affects all aspects of a person's life. So our first speaker is Mr. Keston Singh and team. Mr. Keston Singh and team, they're a group consisting of 8 members pursuing their Bachelor of Science, Bachelor of Surgery degree at the University of the West Indies, St. Augustine campus. This project was started while they were in their 2nd year of medical school, and the members are Chelsea Mahace, Adelia Mathura, Akasha Ramnarayan, Rochelle Romero, Zayla Kaulesa, Randir Maharaj, Keston Singh, and Stanley Mokam. Please let's welcome Mr. Keston Singh and team to look at alcohol and popular music in Trinidad and Tobago.
Good morning, everyone. My name is Keston Singh, and today I have with me Stanley Mukambi. Today we will be presenting on behalf of our group on our topic, the representation of alcohol in popular music in Trinidad and Tobago and implications for health, a content analysis. So to jump right in, I now hand you over to Stanley.
Good morning, everyone. So we have an interesting topic. This would have been an idea by our very own Dr. Maharaj, just basically a content analysis on how music basically affects alcohol consumption. So just to start off, we would say research has clarified that alcohol is a carcinogenic, the psychoactive compound with addictive properties, yet still it remains a norm in our local social interactions. Excessive consumption can result in many negative consequences such as cancer, cirrhosis, depression, just to name a few. Alcohol is also addictive, affecting a person's relationships, overall quality of life, and has profound implications on public health. Trinidad and Tobago is known for its vibrant culture and infectious music, the most popular genres being soca, chutney, calypso, parang. Sorry, give me a sec. Okay, so as I would have said, the 4 main genres. So soca, chutney, parang, and calypso. You may ask yourself, what does music have to do with public health? I'll tell you. In 2012, Anderson and Company found music had a favorable influence on behavior, specifically purchasing through marketing. In 2011, Ingalls provided evidence that lyrical content can influence alcohol consumption. They found that bar patrons who were exposed to music containing references to alcohol purchased more than customers who weren't exposed to music with alcohol references. There was also evidence that alcohol affects our local society. Research suggests that there are vulnerable parts of the Trinidad and Tobago Company. In 2007, Moore and colleagues found that South Asians, also known as Indo-Trinidadians, metabolize alcohol differently due to a variation in the enzyme called aldehyde dehydrogenase, which was mentioned a few times today. Secondly, a cohort data coming from Molokia in 2011 reported that among the mostly Afro-Tobagonian population, males who consumed alcohol have an increase in cardiovascular mortality compared to those that did not consume. Finally, a national survey done by our very own Dr. Maharaj and colleagues in 2018 identified that households where alcohol is used were more likely to experience harmful outcomes such as acute and chronic illnesses, along with intra-household difficulties such as infidelity, violence, and abuse. This study aimed to fill a knowledge gap by exploring how alcohol was represented in popular soca, chutney, calypso, and parang songs in Trinidad and Tobago by analyzing and interpreting lyrics to identify the concepts and themes, and to understand what these concepts and themes were revealed about the writers, the Trinbagonian population and culture, along with possible implications for public health. Firstly, music from each genre which contained alcohol representation was sourced through online searching of platforms such as YouTube and Spotify. We communicated with contemporaries such as friends, family, DJs to find out which songs they were aware of that contained references to alcohol. Songs were then collected from digital sources, and then transcriptions of the songs were found online when available. The lyrics were transcribed by the researchers when no reliable transcriptions were available online. The lyrics were coded for references to alcohol such as rum, beer, liquor, as well as brand-specific references such as White Oak and Johnny Walker. After the songs were established, the utterances were reviewed, grouping them into concepts. Each researcher was then assigned a grouping to choose the best fit utterances from the table, and then after the concepts were further grouped into themes. So here we see a concept grouping occurring. It looks a bit like Einstein at work. And then we refined everything into this. So I now pass over to Justin.
So now on to the findings. 57 songs were identified originating between 1943 to 2022. Of these 57, 4 were calypso, 20 were soca, 23 were chutney, and 10 were parang. From these 57 songs, 3 main themes originated, which included encouraging consumption, drivers to consumption, and discouraging consumption. Under the theme encouraging consumption, 4 concepts were understood: nostalgia, celebration, freedom to drink, and aphrodisiac. Under the theme drivers to consumption, 3 concepts were understood: loss of freedom, loneliness and grief, and stress relief. Under the theme discouraging consumption, 3 concepts were understood: consequences, shame, and addiction. So these were the songs that strongly represented each theme and concept. Under the concept of nostalgia, we had Imran Bihari's song, What We Could Do, with the lines, think about we long time days, think about we long time ways, reminisce about the past, all the times we used to spend, never may come back again, only memories will last, raise a beer to one another, anytime we meet each other. Under the concept celebration, we had Lord Kitchener's song, Drink a Rum, with the lines, drink a rum and a punch a creme, drink a rum is Christmas morning. And Marshall Montano's single, Happiest Man Alive, with the lines, drink a rum and live my life, I'm the happiest man alive. Under the concept freedom to drink, we had Master Salim's song titled Let's Have a Drink. with the lines, if I like to drink rum, why da bother in you? Stop playing judge and jury and find something else to do. Under the concept aphrodisiac, we had Cass the band song, Rum and Soca, with the lines, got the stamina, so I give you what you want, yeah, what you want. Conscious that what I have is what you need, hey, what I have is what you need. Just pass me that bottle in my hand, boy. And Ricky Jai's song, titled Barman with the lines, Barman give me a Guinness and punchin', a supplicant and a ginseng. My wifey day home and she waiting for some sweet loving. Even if I'm tired, it don't matter to she, I have to find the energy to satisfy she. So now moving on to the theme of drivers to consumption. For the first concept, which was loss of freedom in marriage, we had Ricky Jai's single, The Remedy, with the lines, you're talking like my father, acting like my mother, you're telling me what to do. I can't come home sober, just can't take the pressure. And the Hitman single, Mr. Shankar, with the lines, I don't want no more young girl to tie me down, more rum for me, more rum for me. Under the concept of loneliness and grief, we had Ravi's song, Rum is my lover, with the line, Akela Umi. Rum is my lover, and I don't care, and rum killed my mother, rum killed my father, rum killed my whole family, rum killed my brother, rum killed my sister, now it want to come and kill me. We also had Ade Samaru's song titled, Rum Till I Die, with the lyrics, Rum Till I Die, she tell me she don't love me, and that's the reason why. Under the concept of stress relief, we had a lyrical song called Conquer Me, with the lines, when the liquor hit me, I feel like I'm in ecstasy. When the liquor hit me, we train all we stress away. And Marshall Montano's song titled Happiest Man Alive, with the lyrics, I don't got no time for stressing, I had rum in my mind, so I'm ready. Under the last theme, which was discouraging consumption, for the concept consequences, we had K.I. Prasad's single, No More Rum Again, with the lyrics, under rum I meet this girl, now she is lying next to me. Before my wife come back home, I have to get rid of she. And Nigel Gobin and Anthony Batson's single called Stop Drinking So Much, with the lines, so every time when you drink, it is hitchy, so she pack up and she go on by she family. Under the concept of shame, we had The Mighty Sparrows, Drunk and Disorderly, with the lyrics, Drink and drunk, yes, that's my name, always make me family shame. And Nigel Gobin and Anthony Batson's single called Stop Drinking So Much, with the line, every time when you drink, look you're fighting, look the neighbor and them, they're laughing. Look the children, they're stressed and danger, all of this happened because of liquor. And for our last concept, which was addiction, we had Lord Relator's song titled Sip and Chat, with the lines, be moderate and take it cool, don't let alcohol make you a fool. And again, Nigel Gobin and Anthony Batson's single called Stop Drinking So Much, with the lines, you need to change your lifestyle, boy, you have a family now, you're a man, just drink plenty, so much that you never have no money. Like your wife have to borrow from she father to pay off your bills by the bar. You need to sit down and reflect where you went wrong. So how does previous literature relate to our study? Well, international evidence suggested that the representation of alcohol in music can lead to increased consumption. Yet, there continues to be a wide representation in popular Trinbagonian music. The main takeaway of the study was that although many of the teams suggest that music encourages alcohol consumption, some evidence was found to the contrary. What was our main limitation, you might wonder? Well, the infectious nature of the music could not be captured as the study was based solely on the lyrics, and members did not possess the skill set to do an analysis of the musical composition. From this entire study, what recommendations can we generate? Well, the national community needs to realize the risks associated with such lyrics, and there should be a national discourse as to whether or not we should expose our youths and general public to these kinds of music. Another recommendation is future studies should be conducted to examine the behaviors and consequences of listening to these songs and the impact on public health, family life, mental, physical, and financial health, and non-communicable diseases. And last but not least, we would like to thank our Professor Rohan Maharaj and Ms. Masha Ivy for their assistance during this project. Thank you.
Thank you, Caston and team. I thought you were going to sing these songs. I don't know how many people were humming these songs while he was reading them out. I'm guilty. And I think it's only when we actually see the lyrics of these songs, they actually feel like, wow, because some of these songs we humming along, not knowing the words behind it. Thank you very much. Great job. We go straight along to Ms. Rebecca LeCue, Dr. Marcella Nunez-Smith, and Dr. Joan Monin, who will talk on alcohol and the impact on women and families. This is a short film from St. Augustine campus.
Prior research conducted in Trinidad has shown that alcohol use disorder, AUD, can cause major stress on individual family members, as well as entire family units. It can result in a financial drain on families, while also causing conflict in the home. Examples of conflict and stress include domestic violence, child abuse, and driving under the influence. There is limited understanding of how families in Trinidad cope with alcohol dependence. Therefore, we conducted a qualitative study using one-on-one, semi-structured interviews. Our thesis aims to characterize the lived experience of women in Trinidad who have at least one family member with chronic alcohol use. This information may help to inform the development of family-level interventions and alcohol policies in the region. One participant, who was a daughter and a caregiver, described how she grew up with an alcohol-dependent father, who often prioritized drinking over providing for the family. During her interview, she explained the lengths her father would go to obtain the alcohol.
Well, my dad, when he works and he gets paid, he has a family. The first thing he goes in a rum shop or the bar. If he don't get money to buy his alcohol, he goes and sells my mom's jewelry. Whatever he gets, animals, anything. When he started selling everything, he was an alcoholic and he could not do without drinking.
Despite the fact that he sold some of the family assets, this participant went on to describe the unconditional love she had for her father.
I love my father. Even though he does drink, I just love him.
We saw how a sense of family mediates the effects of having an alcohol-dependent parent. The participant greatly valued the idea of family, as well as the idea of having a father. Nevertheless, she explained how having an alcohol-dependent parent affected the qualities she sought in a partner. She loved her father, but knew she never wanted to marry someone like him.
Well, I always say, I don't want a husband as a drinker.
In addition to being a daughter, this participant was also the main caregiver of her ill mother. She described the familial obligation she felt that moved her to take a more active role in her family.
Right now, I am single and I don't have kids or anything, so they more depend on me to do the running around with mommy. Sometimes like clinic and hospital visits and all these things.
Towards the end of her interview, one participant offered advice to other families that might find themselves in similar situations. She encouraged them to love their children unconditionally and give them a solid emotional foundation.
The thing is to love your children no matter what they manifest. No matter whether they're bright, if they're not bright, or academically inclined. That is incidental. You have the privilege of having a child. Try to be like the Creator and give your children unconditional love. It is easier said than done at times, but try to give them so that they have a strong emotional base.
This call for unconditional love contradicted a bit with a statement made by the participant earlier on in the interview, where she described how she used avoidance as a coping mechanism. When the stress involved with dealing with her son became too much, she turned to her brother for support.
A year or two before he passed on, I remember at one point in time I had to call my brother and I said, listen, I'm very emotionally stretched and I can't handle all of this because I had other things handling as well. So talk to him, get a place for him.
Another participant described the difficulties involved with caring for her son, while also protecting him. In her role as a mother, she was still grieving the loss of her son, but her understanding of his death was framed by her faith. She found comfort in believing that God protected her son, as well as others, by taking him away.
But I had my moments when it really, and it still does, tears me up. So no, here was a guy with so much promise, but he had to pass on. That really bothers me. But having said that, I had beseeched God as his mother to help me, to help him, to come to terms with his thing. And maybe voluntarily decide that he needed to be habilitated, and it helped me to cope. And suddenly I got a brainwave. And I said, you know, God has answered my prayers in a seemingly strange way, but in a sensible way. Because the anxieties that I would have endured with him doing this driving and possibly under the influence. I hate to say it, but it's a relief for me to know that he's in a safe place, out of harm's way.
Another participant, who was a daughter and a caregiver, described how she grew up with an alcohol-dependent father. She ultimately found herself in a relationship with a man who was alcohol-dependent and abusive. Their turbulent relationship came to an end after some time, but the participant described how she was still affected by this man even after they had parted ways.
This fear just over you. It's not going to be good. Like you go and you see him have a drink and this and that. That is one thing I always say I don't want, an alcoholic husband, or even to live with a person because of how my dad used to drink. Well, that's why I said I try not to be in one place too much, even in Chaguanas. When I go to shop, I make my little market and thing.
Another participant, who was a daughter and a church member, described how she grew up with an alcohol-dependent father, whose behavior caused a rift between family members. More specifically, she felt pushed to pick sides between her mother and father.
Showing affection for my father was in some way a betrayal of my mother, because it was almost as if this is the man who is doing all these things in this house. This the man who is showing all this to me, and here you go, showing affection to him. Therefore, it means that you do not love me. So as a child, this is how I felt. Very confused. It may not have been intentional on her part, but this is how I felt. If you get too close to your father, a betrayal of me. So how can you be close to him? You know? So it was all right. He is the bad guy, she is the good girl. Let me be close to the one who is good.
One participant explained how her father eventually passed away. Her comments illustrated the many ways in which she was still trying to come to terms with his death and the events leading up to it. Moreover, she was reflecting on the lack of connection she felt with her father.
He died in 1994. But it is very sad because I remember telling someone at the time of his death that it was almost as if he had died even prior to his death because of how bad the relationship was. So he was there in body, but there was no connection really. It was almost as if we had already lost our dad. So it's a case of grieving for the father that you never had.
We saw how connections and relationships between family members are what give a person their substance. This participant's father never truly existed for her because she did not have a real connection and relationship with him. Her family was ultimately able to receive social and financial support through their church, and we learned about the role that this institution played in their life.
I think the church helped us financially. The church kind of kept us as a family, and it kept us in the main outer trouble. We still made mistakes, particularly my sisters, in terms of choosing partners to get married to and, being able to deal with issues within the marriage. But it helped.
The data shows how various social contexts and economic realities mediate the roles that family members of alcohol-dependent individuals play. Participants described their roles as mothers, partners, caregivers, and daughters. The central social contexts that emerged include membership to a faith-based communities and familial relationships. Economic mediators centered on familial obligations to provide for one's family. Ultimately, a tension emerged between how these individuals understand their roles within the family and the reality of their lived experiences. The findings highlight the impact of alcohol dependence on families and communities. Understanding the complex experiences of women in Trinidad, with alcohol-dependent family members, may help to inform the development of family-level interventions and alcohol policies in the region.
I think hearing real life story kind of bring all the points across, and it shows us the impact of alcohol, not just on the person, but on their loved ones. The social impact is very important. Our third speaker in this session is Dr. Paul Bourne. Dr. Paul Andrew Bourne is a social epidemiologist, a health demography statistician, public affairs commentator, a poet, and a prolific author. He's an avid researcher who published over 200 scholarly papers, including a study that is hosted on the WHO website entitled An Evaluation of Domestic Violence Against Jamaican Women During the Coronavirus Pandemic. He attended numerous health, education, and social conferences and is involved in community activities inclusive of media presentations. In 2019, both he and his colleague won the most outstanding poster student presentation at the Ministry of Health and Wellness 10th Annual National Health Research Conference. Dr. Bourne is currently the Acting Director of Institutional Research and Honor Society, co-coordinator at the Northern Caribbean University in Mandeville, Manchester, where he holds a doctorate in education with specialization in leadership and management. Please let's welcome Dr. Paul Bourne, who's going to talk on alcohol and use during COVID in Jamaica. Dr. Bourne.
Thank you very much, and all protocol observed. The presentation earlier for me is personal, because I remember years ago when similar in terms of trying to pick side between my mother and stepfather, and my stepfather was a drunkard. So that one came close, extremely close to home. So today I want to present to you a study that was done on alcohol consumption during the COVID-19 pandemic. Are you seeing my screen, ladies and gentlemen?
Yes, we're seeing your screen online.
Yes, we are, Dr. Bourne.
All right, thank you very much.
You're welcome.
So, the issue of alcohol consumption, without a doubt, is something that we need to address. And what we are realizing, there's a high prevalence in terms of alcohol consumption among the young population. And a number of persons have actually spoken about that prior to my presentation. And there are a number of risk-associated behaviors with this alcohol consumption, this negative behavior, and there are a number of negative consequences in terms of consuming alcohol. Now, many studies have been done in terms of alcohol consumption, in terms of a certain population, and the figures are there in front of you. I won't be reading my slide. I'll just speak to you in terms of what is the situation. Now, various countries, and we're not talking only about Jamaica, we're talking about Brazil, Australia, Germany, and many other countries. Is relating to alcohol consumption is really a matter. High percentage of individuals have been actually consuming alcohol. But we have to speak about the young adults. We're talking about those 18 to 25 years old. In the critical group of persons who are either going to universities or in the working age population, a critical group of persons, and a number of them are involved in a number of substance abuse, of which One of them is alcohol when they actually go to these functions that they go to on a weekend. Now, a study was done in Jamaica that actually spoke about the matter relating to alcohol consumption. Again, look where Jamaica is ranked in terms of alcohol consumption. A small country with 2.8 million persons, and look where it's ranked in terms of alcohol consumption. So that is indicating to us that this alcohol consumption is really at an epidemic level in Jamaica. Now, we use a theoretical framework that look at alcohol consumption in terms of life expectancy as it relates to what goes into the alcohol consumption and what are the factors that come out, or what is it that come out of alcohol consumption. The literature review is extensive on alcohol consumption, and the National Council on Drug Abuse in Jamaica has been actually looking at this thing relating to alcohol consumption and other substances as well. Now, United Nations as well has also given us information on alcohol consumption, and they state figures that are there in terms of alcohol consumption. Now, what we wanted to do was do a national study during the COVID-19 pandemic to assess what was happening in terms of the prevalence of alcohol consumption. So the study was done between May and June 2021. All parishes in Jamaica, it was a web-based survey, and the questions were actually designed based on looking at extensive literature on the matter to ensure that we cover all the areas that we would want to look at. Of course, informed consent was actually done in terms of how the survey was designed online. Data was entered into SPSS. We use a p-value of 0.025, because we use a two-tailed test to determine what is it that we'll be doing to analyze our data. So here we go. 500 Jamaicans were actually sampled. Almost equal in terms of percentages, and look at the age cohort. As we said before, data was gathered from individuals who are 18 years old and beyond. And the rationale for choosing 18 years old, because we were saying that no one in Jamaica using the law should be consuming alcohol before 18 years old. So that was in context of that, as well as the issue relating to informed consent. That will have to get informed consent from parents and every other person in terms of the sample. So we chose not to go to the population lower than 18 years old. A number of things were actually discovered with our survey in terms of, do you consume alcohol? And you look at the reasons what drove people into consuming alcohol in Jamaica. Isolation from friends and family, 15% of persons, 15.7. Financial instability, 28% of individuals. 28%. Worried about being affected by the virus, 15.5%. And other things, 40.6%. So it indicates to you that the lockdown that happened during COVID-19 was creating an impact on individuals that were at home. And many of them turned to alcohol as the way out in terms of that. Now, we also look at issues faced during the pandemic, and a number of these individuals were depressed. 34.3% of individuals that were sampled indicate depression. And we are saying, remember that a number of them said that they were isolated from friends and family. So they were at home, frustrated, and turned to alcohol as a resort out. Something that we actually discovered from that. How many persons that have consumed alcohol in their lifetime, to the point where the research was done, almost all Jamaicans, 92.2% of the individuals indicated they have consumed alcohol. Look at the age distribution and what time they actually started. Very young. And we need to understand clearly that we need to start a message in terms of getting as close as possible to our young persons as likely, because we're talking about 68.8% of them indicate that they started between 18 and 25 years consuming alcohol. Very early in their life, started this alcohol consumption. Now, has your alcohol consumption changed? Did it change during the pandemic? 42.4% of the individuals said that as well affected your drinking habit. 47.7% said that started drinking more as a result of what was going on. 42.2% of them indicate that an increase in consumption of alcohol. during the pandemic. Now, let's now look at some other things that were actually going on with our Jamaicans during the period of the pandemic. And we're talking about in 2021. Does drinking affect your ability to sleep? 40% of persons said yes. Drinking was affecting their ability to what? Sleep. If you look carefully at what the results that came out of the question, describe your health in general, you realize a number of persons actually say that their health is good. So only a few individuals are claiming that their health is bad, despite the fact that they're having problems sleeping, despite the fact that they said they were what? Socially isolated, despite the fact that they said that they were what? Depressed. People's health was relatively good. Do you believe that alcohol consumption can affect your health? And look at the numbers, and this is the part that I found staggering. Agree, 38% agree. Look at the number of persons who say that they strongly agree, 42.2%. So if you put strongly agree and agree together, persons are aware that alcohol consumption negatively affects their health, yet still they are doing it. So we need to understand clearly that persons know that they should not be consuming alcohol, and they are doing just that during the period. Now, we also disaggregated the data in terms of during the last year, in terms of being emotionally distressed and looking at if they consume alcohol. Let's look at the table carefully now. During the last year, have you had any form of what? Emotional distress. 94.3% of those persons who said yes were consuming alcohol. So this is what alcohol is doing to our individuals in Jamaica. We also asked them in terms of for them to actually tell whether they were depressed, whether they were anxious, whether they were suicidal, whether they were paranormal. These issues, and we actually disaggregate that now in terms of their alcohol consumption. Let's look at those persons who say yes. Of those who indicate that they were depressed, 93% of them were consuming alcohol. Of those who indicate that they were anxious, 96% of them were consuming alcohol. Of those who indicate that they had suicidal thoughts, all of them were consuming alcohol. Paranoia, 89% of persons were consuming alcohol. So it actually tells you that the psychological state of these individuals during COVID and how they were taking alcohol as the resort to the psychological state that they were actually going through. What have we substantially learned from this research is that alcohol consumption fundamentally is influencing people's mental health status, how they view things, what they are actually going through, and that the COVID-19 pandemic was actually putting much strain psychologically on persons. And what they were resorting to deal with the state that they were now in as a result of the pandemic, the lockdown, and the financial instability was turned into substance called alcohol. Where should we actually look at moving forward? Because one of the things that we need to understand clearly is that whereas COVID-19 may have died, the possibility exists that some other pandemic may arise and we may be resorting to a lockdown again. So we need to understand clearly and make some policies and deal with that likeliness that should this occur again in the world, we need to find policies and systems to ensure that we can mitigate against the lockdown and what lockdowns are likely to cause people, and how depressed they are likely to be, and how they are going to be resorting to alcohol. Of course, the study did not look at their behavior when they actually consume the alcohol. But what we do know is that the alcohol consumption rose significantly during the COVID-19 pandemic. And many of our people who were suffering psychologically were turning to alcohol instead of another sort of measure to deal with their issue. Thank you, ladies and gentlemen.
Thank you very much, Dr. Bourne. And I remember a question was asked earlier about the impact of alcohol on a person's mental status. So this answers one of our questions from before. Thank you very much. So we have a brief question answer segment to close off this session. Any questions from our live audience? Any questions from the online audience? Yes, ma'am, go right ahead.
One question, thank you. It's for Dr. Bourne. Someone mentioned earlier that in Barbados there were restrictions on during COVID, you weren't allowed to purchase alcohol. They were actually locked up in most of the stores. So I was just curious if anything like that was done in Jamaica.
No, that was not the case in Jamaica. What happens, a number of the outlets were actually closed, where persons find a way to get the products.
Yeah, okay. Thank you so much.
Thank you for that question. Any other questions? Any other questions online? Okay, great. Thank you so very much. Please let's give a round of applause to all the presenters for this morning's session. Thank you so very much. Ladies and gentlemen, those physically here, lunch is served. Those of you online, bon appetit. So for those physically here, as we come out the door on the right-hand side, but to my right, we have a beautifully laid table, 3 signs, chicken, fish, and veggie. Happy lunch, and we'll be back here to start our last session at 1:30 p.m. on the dot. So see you all soon. Thank you very much.
We are about to start the afternoon session, so if I could ask everyone to return to their tables. And before we start, some of you may not be aware that a bit of sad news. We had the passing of Dr. Carissa Etienne. I'm not too sure if you all are aware. She, let me not get this wrong. She was the former director of PAHO. Yes, Dr. Carissa Etienne, she died at the age of 71. So we'd like to just observe a moment of silence in her honor. So if I could ask everyone just to be silent for a few moments. Okay, thank you. All right. You should be well acquainted with me. I presented this morning by Dr. Ravid Khan, together with Dr. Shashri Mutila, will be co-chairing this afternoon session. All right. And next on the agenda, we have a very seasoned researcher. He now retired from the university. Right. He's a former senior lecturer at the Unit of Public Health and Primary Care at UWI St. Augustine. That's none other than Dr. Camille Mongru. So I want to invite him to the podium to deliver his presentation this afternoon. And his presentation is entitled Alcohol and Primary Care in Trinidad. You could use this to go forward, to move forward, so I need to watch it.
Thank you very much, Ravid. And congratulations to all those who have organized this seminar, particularly Prof. Alcohol has impacted upon my professional development from the time I graduated. And when presenting this paper, I reflected on my early days when I graduated in our final year at Port of Spain General Hospital. The final year medical student used to make rounds. So there was, you had the consultant and the final year medical student. And I did a stint with Professor Bourbon. And in those days, the impact of alcohol was profound. we would see people with DTs, as we call them. We used to call them. And Prof used to walk around with CPZ. I don't know if they still use that, Sandra. Sometimes. And he would walk around with this thing in his back pocket. And if you know Prof Bourbon, he was a gentleman. Never heard him spoke loudly. Or he was also senator in the parliament. And he would walk around, and in the obstreperous patient who was carrying on, he would walk quite gently to the patient, and in the flash of a moment, he'll pull out the CPZ, inject the patient, and everything was calm. And that is my perception of psychiatry. Now I've waked you up from your postprandial. Let's get on with the present. So, alcohol has had a profound. Sure, thank you. It has a profound effect on the human body, and I thought I would take a few minutes just to capture some of the things that we, as I said, we used to see. I don't know if we still see these extraordinary things anymore. And I start off with the effects on the CNS, and we heard this morning about breath analyzer. That was introduced in 2009. It used to be very aggressive. So driving on the highway, the police officers would stop people, and you can see them doing the test. I don't see that anymore. So I don't know what has happened to the breath analyzer test. But alcohol, as I have listed here, has important central nervous system consequences. In addition, it can affect the heart, pancreas, and liver. And hypertension is specifically important because a recent study has shown that the prevalence of hypertension in our setting in Trinidad is as high as 55% of the population. That's enormous. And some people say 60%. So that's almost two-thirds of the population of Trinidad and Tobago has high blood pressure. And one of the advice that you will give is to reduce your alcohol consumption, but it does impact upon hypertension, atrial fibrillation, cerebrovascular accidents. Again, in my early days, we used to see a lot of patients on the medical wards. So I spoke about the impact on psychiatry. But on the medical wards, acute and chronic pancreatitis was common. Okay, of course, liver disease, and not esophagus was probably the most common of the cancers. Again, I come back to, I don't know, Sandra, do you still see Korsakoff's psychosis? Not so much, but in my time, Wernicke's encephalopathy and Korsakoff's psychosis was quite common. And the patients would describe to you, I see the pink elephant. Yes, I've heard that with my own ears. The patients would give these kinds of descriptions. Bipolar disorders, anxiety, and memory impairment. And so I've laid the foundation that alcohol has significant impact on health over a broad spectrum. And unlike cigarette smoking, which also has profound effects, we introduce smoking cessation clinics in some of the RHAs. They were poorly attended, so poorly attended that the one in Arima, which I'm familiar with, have no patients. But I've never seen any attempt at the primary care level to have clinics with the same kind of philosophy to try to persuade people about their drinking patterns. And so when we wrote this paper, which was published in the Journal of Alcoholism, it was meant to shed some light on what could be the possibly primary care approaches to alcoholism. The intention of that study was to determine the proportion of individuals consuming alcohol, describe the patterns of alcohol consumption, and to determine the prevalence of hazardous drinking. So we used the CAGE. Remember, this study was done and published 2012. So that's a fair time ago. That's about 11 years ago. But CAGE at that time was the questionnaire that was in the literature as the most efficient way to assess alcohol consumption. So a questionnaire was devised. We used the CAGE questionnaire. I reported on the sensitivity, which is about 93%, which is not bad. Sensitivity, okay. Specificity, sorry, is a little bit low, but certainly the sensitivity is quite high. We defined hazardous drinking as 14, we use a WHO definition, which is more than 14 drinks per week. I don't know if that has changed. Pardon? For males. Okay, thanks. So in that study, we randomly selected 865 from the 4 regional authorities in Trinidad. And that's a huge undertaking. Try to get a research project in one RHA. It's pulling teeth. So you have to go through 4 ethics committees to get an approval. I don't know if we have anybody from the ministry, but certainly we can attempt to make research in important areas a little more accessible. But just to get each RHA ethics committee to approve, it's really horrendous. But we were able, so we had a fairly broad area of subjects, and we entered 865 people in this study. The estimated prevalence of alcohol consumption we can report was 60%, with a 95% confidence interval reported. The estimated prevalence of hazardous drinking was 18%. And among those with hazardous drinking, men were more common in men than women. Among the 422 CAGE respondents, 69% had elevated glutathione transpeptidase. I don't know if we still use that. Do we? Yes, we do. It's pretty good for confirming whether the patient has an alcoholic problem or not. And it's not very expensive, even at that time when we did this study. And so we used that as a method to validate our findings. And that was taken at the time of the interview. So we provided evidence that the prevalence of alcohol consumption was approximately 60% in a primary care setting. And 16 to 18% consumed alcohol at levels which put them at risk of developing alcohol-related harm, which I listed at the beginning of the presentation. Right. So that The essence of the study was to provide evidence to demonstrate that unlike but similar to smoking, we should have some primary care approach to alcohol and alcohol consumption. And at the beginning of this year, our Honorable Prime Minister made a remark. He said that for crime is a public health problem. And there's much controversy with that comment. But in actual fact, it's a comment that I agree with. Why? Because if we can understand crime as a disease, then we can begin to understand the epidemiological features of that particular, whether it is alcohol consumption, cigarette smoking, or crime. And if we can understand the disease, and we can understand the epidemiological features of that disease, by that I mean who gets the disease, where, when, how, all the questions, as well as understanding the social determinants of disease, which is where the person lives, where they're born, live, go to school, and work, and die. Those are the social determinants of health. And if we can understand those things, we can begin to have a primary care approach, like smoking, for alcohol consumption. And that's my sell to this particular conference. Thank you very much.
So Dr. Mongrou wouldn't be around at the end of the program, so just wanted to change the format a little bit. If there are any burning questions, could you pose it to him now, either online or live, before he makes his exit?
Thank you very much. Yes.
So thank you for, I think what you're alluding to with getting alcohol cessation and alcohol, addressing the disease of alcohol harmful use in primary care is really important. And I actually going to ask just, what are your suggestions of, not like, so smoking cessation, we have these cessation clinics where anyone who uses tobacco and its products can come into these clinics. Do you think we can use the same model? And
of course we can.
Right.
Because public health doesn't change that much. And so we could use, but it's to get those who are, we have to get the RHA involved. And those who are the decision makers for health and the impact that certain, for example, smoking and alcohol, that these are impacting adversely on people's health. And there are opportunities that we can make available to help people. And that's the message. How do you convince the RHAs to do that? Now, mind you, the health services do have their challenges. Yesterday I was advised that there are some medications that people have not been able to acquire in the health centers. So that, but I'm not suggesting that we do anything, extraordinary that is very costly. But we can start somewhere.
Yeah, I think this is something that we can piggyback, because even this morning we were talking about how this whole dopamine pathway and the short-seeking pleasure reward systems, and when persons indulge in alcohol, they're more likely to make these decisions that are pleasure and immediate seeking that ends up in the road traffic accidents, the sexual consequences, all these things. Do you see a role where these clinics can, in primary care, be more of a like incorporating tobacco, alcohol, and I think it'll have to be a multi-team approach where we incorporate both the pharmacological aspect and the non-pharm. So things like psychiatry, psychology, even dietitian support, all these things, we'd have to establish those things.
Yes, and that's quite true. But bear in mind that we are challenged with two chronic diseases that, for example, we have a chronic disease clinic in Arima that the clients can only get 6-month appointments. So if I see you in January and I prescribe your hypertensive medication or your diabetic medication, I don't see you until June, or sorry, July. And that's, I don't know how you can manage a hypertensive or diabetic with such a long gap. But these things are costly. So while, you know, it's easy to stand here and, you know, make these proposals, they are costly because you have to have staff and you have to have resources. You can't just see the patient. If the patient needs to be referred, you have to have clinics where they can go to. Again, resources are a major constraint. Yes. Yes.
So I just want to contribute to the discussion. My name is Diane Hene, and I'm the General Manager of Nursing for NCRHA. In addition to what Professor has said, at ARIMA, we came up with an innovative way to treat with the diabetics. It's called the Diabetic Self-Management Education Program. So even though they get the clinic appointment, we teach the public, the diabetics, to self-manage. So those education programs are managed by the doctors and the nurses. So we teach in self-management. So all of that contributes to the whole picture of the diabetic management.
And as you mentioned that, I will add to that because recently there's something called HEARTS. And I think that that's a wonderful thing because HEARTS now allows all the players to know what drugs to use. So you can place the patient, the hypertensive patient, into a protocol A or B. And so in the notes you can write protocol B, irbesartan 150 milligrams, one daily, amlodipine 5 milligrams. And that goes throughout all the RHAs. And to me, that's, so if we have that vision to develop something like that, where you have consistency across all the RHAs, would be a worthwhile achievement. Thank you.
Okay, thanks very much, Dr. Mongru, for sharing your experiences with us in the treatment of the patients with alcohol use disorders and for highlighting the findings of your study conducted in 2012. So colleagues, we move along in the program. Next in the agenda, we have someone who's no stranger to me. She was my teacher, lecturer in medical school, and have the privilege of working with her now at the University of the West Indies, St. Augustine. She's none other than Professor Sandra Reed. She is now a professor of public health psychiatry and the president of the Caribbean Institute of Alcohol and Other Drugs, CARIAD. Got that correct, Prof? Yes. All right. And she is here this afternoon to present to us on a topic entitled Alcohol and the ER in Trinidad. So let's put our hands together and welcome Professor Reed.
Good afternoon, everyone. And I'd like to thank Dr. Khan for his introduction. Oh gosh, Dr. Khan, you make me feel old. But it's so good to see the people that you have taught grow and flourish and, you know, become your colleagues and outstanding colleagues at that. So thank you very much. I would like to start by commending Professor Maharaj and his team and the Healthy Caribbean Coalition for this venture. It's very important. Alcohol harm reduction in the region is not an easy task, as I'm sure he has recognized, but it is something that we need to do. So what I'm going to do this afternoon for the next 10 or 15 minutes or so is to look at the importance of research in determining harm reduction activities and harm reduction policies. So we're going to be looking at data that was collected in 2015 on injuries and accidents in emergency departments that were caused because of alcohol use. So there's quite a bit of research globally to support the fact that alcohol is a significant risk factor for accidents and injuries. So I'm not going to bore you with all of that literature, because if you go on Google, you will find regionally, locally, globally, data to support that statement. This study that was done in 2015 was actually done as a part of the World Health Organization collaborative study on alcohol and injuries, which assessed the role and extent of alcohol involvement and the type and context of alcohol-related injury among patients presenting to emergency rooms in Trinidad and Tobago. Before we go forward, I just want to take a few seconds to acknowledge the grant funding that was given by PAHO WHO through the Trinidad and Tobago office for this project, and the statistical support that was offered by my colleague and co-author of the publication that arose from this research, Dr. Janelle Gentius. So the objectives of the study were straightforward: to document the proportion of patients with non-fatal injuries who were intoxicated with alcohol in a probability sample of emergency room patients at the 4 largest general hospitals geographically distributed throughout Trinidad and Tobago. So Dr. Mangru, I had the headache too, because you're dealing here with multiple RHAs. The study also looked to examine and understand the context in which the drinking had occurred and to determine associations between patterns of drinking and injuries. The methodology followed the protocol of the WHO Collaborative Study on Alcohol and Injuries. So we got ethical approval from all of the necessary bodies, and the next step was the cultural adaptation of the standardized WHO Collaborative Study questionnaire. Adaptations that were necessary were primarily for language, for the examples of the types of alcoholic beverages that were used, and the expression of quantities of alcohol that respondents could identify with: a bottle of beer, a glass of, appropriate examples. The adapted questionnaire was used in the pilot, following which minor adjustments were made to the flow of the question. The study utilized 12 university-qualified field workers, all of whom had prior research experience, and they were trained to administer the questionnaire as well as the Alcosensor 3 breathalyzer. We then met with senior medical and nursing staff in each hospital to discuss and develop logistical flowcharts, which would determine the practical details of how the data would be collected. Data was collected from May to October 2015. I think those months are important. They did not include Carnival, and they did not include Christmas. The field interviewers posted in the emergency departments utilized the inclusion criteria to determine who to interview. So eligible patients would be over 18 years of age, they would be able to give informed consent, they must have presented to the emergency department within 6 hours of their injury. That too is another important methodological consideration, because we found that there were many patients who had drunk alcohol and were coming the next day or even 2 days later because they delayed help seeking. And also, patients would be those who were presenting for the first time for that particular accident or injury. Eligible patients gave informed consent before data was collected, and the interview averaged about 25 minutes. A total of 329 patients met the criteria to be eligible for the study, and of these, 237 consented to the interview. So that was like 72% of persons. The specific data that was collected is shown on that slide. So the questionnaire collected data on the type, cause, place, and context of the injury, duration, timing, quantity, and location of alcohol use prior to the injury, the context in which drinking had occurred prior to the injury, drinking patterns in the prior 24 hours, 1 week, and 12 months prior to the injuries. You know, we need to get an idea of what the regular drinking pattern is compared to what was happening on the day of the injury. And of course, your usual patient background information on education, employment, income, residence, ethnicity, and so. And alcohol consumption was validated by breath analysis for alcohol using a breathalyzer. Participants were generally cooperative, they engaged easily, but the biggest challenge was getting consent for the breathalyzer test. 36% of patients declined the test, and the most common reason given concerns about legal consequences. So we know that the breathalyzer has a reputation out there, and it also tells us too that they may have been minimizing their reports. What did the study show? Firstly, like so many previous reports, recent alcohol use was associated with presenting to emergency departments for accidents and injury. 20.6% of patients indicated that they had consumed alcohol within 6 hours before their injury or accident. The persons who drank within 6 hours of their injury were mainly male, 83%, and younger. The average age was 34 years. 27% had completed secondary school, that was the modal value, and the majority were employed, 74%, and worked at least 30 hours per week. Among these persons, the most commonly consumed alcoholic beverage was beer. Now, I want you to remember that the 2020 to 2025 US dietary guideline recommendations for adults drinking without harm suggest that women should have 1 drink or less in a day, and men should have 2 drinks or less in a day. Among patients who sustained injury after drinking in this study, the mean amount of absolute alcohol consumed before the injury was 90.6 milliliters, which is about 6 to 7 standard drinks. The mean total absolute alcohol for those who were drinking beer, which we said was the most common alcoholic beverage used, in the 6 hours before their injury was 76.71 mils, which corresponds to about 5 beers. And there was a range of 14 to 336 mils. And if you do the calculation, that's 1 beer to 24 beers. 41.7% of persons had consumed more than 60 mils of alcohol in the 6 hours before their injury, and that's 4 standard drinks. And interestingly, the amount of alcohol drunk 6 hours before the injury was not statistically higher than the amount typically consumed in the prior 12 months. So we had a cohort of persons who were drinking heavily all the time. 63.8% of the patients submitted to breath analysis. Among the 30 persons who were breathalyzed, the mean blood alcohol concentration was 0.07 grams per 100 mils with a standard deviation of 0.08. Most persons, 40% of them, recorded a breathalyzer level of 0, which is not surprising because, even recreational drinkers might have admitted to drinking in the prior 6 hours. And it's not surprising that those persons might have recorded a breathalyzer record of 0. 36.6%, however, recorded levels over the legislated legal limit for driving, which is over 0.08. And the maximum blood alcohol concentration that was recorded was 0.32 grams per 100 mils, which is 4 times the legal limit. What this study really added to the local literature, however, was information on the types and contexts of injuries associated with alcohol use. Injuries were mainly unintentional. When they were intentional, they were inflicted by someone else rather than self-inflicted, which surprised me because I really did expect, and my psychiatric colleagues would agree with me, to find some persons who had attempted suicide as a result of alcohol consumption. But in this particular study, we didn't find that. Chi-square test of independence showed that patients were significantly more likely to have penetrating injuries and open wounds than any other type of injury, and that was statistically significant. Those who presented with those types of injuries recorded the highest mean alcohol consumption totals in the 6 or less hours prior to their injury, and the equivalent was 7 to 8 drinks. How were these injuries sustained? Most patients sustained injuries because of falling or tripping, 31.7%, or in a motor vehicle collision where they were either a driver or passenger. Combined, that was 29.3%. Others indicated things like stab, cut, a bite, blunt force injury or so. Chi-square test of independence showed that there was no significant difference in how likely a particular mode of injury occurred. So all of these types of injuries were happening to everybody. Examination of the mode of injury by age group, however, shows that in all the age groups, except the youngest, 20 to 29 years, the commonest method for sustaining injuries was through falling or tripping. And in the 20 to 29-year age group, motor vehicle accidents was the most common mode of injury. Chi-square test of independence showed that no particular age group was significantly more likely to sustain any particular type of injury than the other age groups. Patients who suffered injury by falling or tripping recorded the highest mean amount of absolute alcohol consumed compared to persons who had other types of injuries. 29% of persons presented with alcohol-related injuries sustained through road traffic accidents, whether they were the driver or the passenger. However, previous research done in Trinidad and Tobago has practically focused on the role of drink driving in causing morbidity and mortality from MVAs. So our public health interventions have primarily carried a message of don't drink and drive. And the major legislative intervention has been the proclamation of the Motor Vehicles and Road Traffic Amendment Act, which in 2009 allowed the use of breathalyzers. But here we are finding in this study that the commonest cause of injuries associated with alcohol was actually the occurrence of accidental falls. And this wasn't unique to our population because it's an association that has been previously described in other populations. Likewise, injuries were not occurring most commonly in a vehicle. Generally, prior to the accident or injury, patients were just as likely to be in their homes, 27%, or drinking at someone else's home, another 27%. 16% of patients with alcohol-associated injuries were at a pub or some other public drinking place prior to their injury or accident. Most patients indicated that they were at an outdoor public place when the accident occurred, followed by being at home and then in a private vehicle. They tended to be commuting, traveling, or walking at the time of their injury or accident. We said that most persons sustained injury because of tripping or falling. Among the persons who fell, most of them, 50%, were likely to fall at home rather than outdoors or at someone else's home, at their own home. For individuals who drank outside of their homes or at someone else's homes, their injuries occurred outside. None of those individuals incurred injuries in their homes. So all persons who were drinking at home incurred their injuries at home. Looking at their general alcohol use, both heavy episodic drinking and acute alcohol intake are again shown to be associated with increased risk of alcohol-related injury. The rate of injury is greatest when both acute and regular use are excessive. Now, the World Health Organization defines heavy episodic drinking as drinking 60 grams or more of pure alcohol on at least one occasion in the past 30 days. And like others, WHO ranks heavy episodic drinking as one of the most important indicators for acute consequences of alcohol use, including injuries. The general pattern of consumption of alcohol among these patients who were presenting with alcohol-related injuries in this study was of chronic heavy drinking. The average consumption was 102.7 grams. Remember what WHO says, more than 60 grams. They were 102.7 grams in one sitting, and 41.7% reported heavy drinking of more than 60 grams of absolute alcohol prior to the injury. Greater intake of alcohol had a greater association with falling. And as stated before, those who were injured by tripping or falling recorded the highest mean alcohol consumption, suggesting a particularly increased risk of unintentional falls with heavy acute use. How does all of this translate to action? This slide summarizes the key points that should guide public health interventions and policies. 1/5 of patients presenting to the emergency departments presented because of accidents and injuries had had acute alcohol intake prior to injury and or heavy episodic drinking as their general pattern of drinking. It is recommended then that all patients presenting with injuries should be assessed for patterns of risky drinking, including a brief screening tool, something like the audit. Dr. Mangru spoke a little while ago about the CAGE questionnaire. Those reporting heavy episodic drinking should receive brief interventions to reduce alcohol intake. That's an easy uptake. That's not difficult to implement by any means. Next, most of the alcohol-related injuries occurred in outdoor public spaces while commuting, traveling, or walking. So clearly there's need for interventions to increase the safety of pedestrians and commuters who have consumed alcohol. And thirdly, most drinking occurred in private homes. When drinking was at home, injuries were sustained at home. Half of the patients who fell after drinking did so at home. So there is a need to develop safety guidelines and other interventions to promote safer use of alcohol in private spaces. Public health policy initiatives are needed that restrict the availability of alcohol. Like any other study, this one had limitations. The main ones related to possible underreporting of alcohol and the fact that we may have only gotten conservative estimates of the number of persons who had consumed alcohol for reasons that I pointed out earlier. The period of data collection did not include our high-use seasonal period, and the study collected data only from those persons who met the 6-hour requirement. And also, we did not include patients who might have sought help from private hospitals or community health centers. So with that, I end my presentation. Thank you very much.
Thank you very much, Professor Reid, for your very enlightening presentation there. Lots to glean about the dangers of consuming alcohol, especially when superimposed on chronic heavy alcohol use and the implications of falls and so on. Thanks so much for sharing that with us. If you stay into the end, we'll have the questions at the end of the segment, if that's okay with you. So moving on, colleagues, we have with us a student, a medical student, who is supervised by none other than Prof. Rohan Maharaj. He is Mr. Andre Ratan Singh, right? And he would have completed his year 2 project, as I said, under the supervision of Professor Rohan Maharaj. And he is here to describe his team's work on a review of systematic reviews on high blood pressure and alcohol. So could you kindly welcome to the stage Mr. Andre Ratan Singh.
Yeah. All right. Thank you, Mr. Chairperson. Thank you all very much. Those of us in person, those of us online, thank you very much. All protocols observed. My name is Andrew Ratan Singh. Also, special thank you to Professor Maharaj for this opportunity. It is quite an honor. So alcohol is one of those interesting points where we can actually see culture directly impacting itself onto healthcare. Today, we've discussed in exquisite detail, might I add, the different manifestations, the myriad of manifestations that come about from alcohol use. I'd like to add one more to the docket, which is a systemic manifestation, that being hypertension or high blood pressure, right? So this actually is an umbrella review or an overview of systematic reviews that my team would have done all the way back in year 2. Today is actually my last teaching day of year 5. So why is it important? So we'll start with a little introduction. So the WHO actually reports 2 billion alcohol users globally. That is a whole lot. Alcohol is also a major risk factor for, again, the myriad of diseases exquisitely described today. Alcohol-related deaths also contribute towards the burden of disease worldwide. Relevance to public health. Well, alcohol has been linked to over 60 medical conditions, and they contribute to over 200 non-communicable diseases. So this also necessitates the need for preventative measures. And this will come in the further steps part of my presentation, which I have cleverly named Next Steps. So our study design, right? So our study aim was to investigate the relationship between alcohol use and the development or progression of hypertension. And we sought about doing this by evaluating the quality and relevance of existing literature, primary research, meta-analysis, systematic reviews, etc. This is just I included this because I quite like this Prisma flow diagram, but it shows how we went from all of our search terms, and we identified originally 10 high-quality papers, and we whittled that down all the way to six very strong systematic reviews. And this is what the results showed. So observed odds ratios in the 3 largest studies out of the 6 showed 1.14, 1.77, as well as a 1.42 odds ratio. When we combined the odds ratios across the 6 reviews, we found an odds ratio of 1.55. This demonstrates a dose-dependent association between alcohol use and hypertension. Just some characteristics of the systematic reviews that we looked at. So we covered various aspects, or I should say the studies covered various aspects: gender-only risk, gender-race associations, as well as genetics, far too complicated for me to properly explain. This is our forest plot showing our odds ratio of 1.55, line well beyond, or well in front of the line of no effect. So what exactly did we find from this big study? I only include the number of participants because I thought it looked like a lot. It's 1.1 million participants. Right, and so again, our calculated odds ratio is 1.55. So these are some more interesting stuff that I think you all might find quite interesting. So the overview showed a greater risk of developing hypertension in men regardless of the category of drinking level. Meaning if you drink a little bit, if you drink a lot, if you're a male, it is going to increase your risk of hypertension. At light alcohol consumption levels, women showed no increase in the risk of developing hypertension. We went over this, we checked the numbers, that's just how it is. This is not a recommendation to drink a little bit, right? But I mean, it is hypertension, so, pinch of salt, I guess. So speaking of which, 1 or 2 of the papers actually postulated, well, maybe there's a protective effect in women to hypertension. However, pouring through the data again, we found nil supporting evidence of this. It's just that at very, very low levels, as Prof was stating at the very beginning, maybe body weight, maybe body water, body fat actually interacts. So studies comparing regional differences, this is quite interesting. showed a greater risk of developing hypertension in Asian, this is also including South Asian men, at similar alcohol consumption levels as compared to individuals in a Western region. One study, so I quite like this one, even though it's quite complicated, Shen et al. In 2008. This was quite unique. So this actually looked at the genetic background, the ALDH genes, and this study, even though it was looking just at the genetic background, what they found was that still, even at a genetic level, alcohol consumption increases the risk of developing hypertension. What about gender-race relations? Studies investigating these types of relations showed higher hypertension risk in individuals of African descent compared to Asians or Caucasians at similar alcohol consumption levels. And this suggests that there may be a potential racial modification of the association between alcohol and hypertension. Some strengths and limitations. So firstly, our overview synthesized systematic reviews. We used AMSTA protocols to confirm the quality of our research. In terms of limitations, so there's one big limitation across all umbrella studies, and this is called overlap. If you look at 6 systematic studies, all focusing on the same thing, they are going to include similar primary studies. There wasn't necessarily a protocol in place to deal with this, but we attempted to do this by instituting what's known as a primary study matrix, where all of the individual systematic reviews are broken down by their primary studies. And so we can actually see graphically or on a table how many they have in common. So this is the fabled next step that I thought was quite cleverly named. Where do we go from here? Well, economic burden and national policies. So we need to be able to highlight the economic impact of hypertension and the need for robust policies based on the study by Abdul Qadri et al., if you all are familiar with it. So this was the particular study that looked at the economic cost of tobacco. And it's one of the first things that actually jump-started the public's awareness of the dangers of tobacco, because all of a sudden, big business meant a little bit less. And we also need to emphasize the call for national policies and WHO-based regulations. Patient-centered programs. I'm quite passionate about this because I do sincerely believe in patient-centeredness. I believe I was taught well in family medicine. So we need to implement programs within the healthcare setting to educate and support patients dealing with alcohol use disorder. There was a very long and interesting conversation about that prior, so I won't go too much into detail. Global health initiatives. So we need to embrace and adapt programs such as the Global Heart Initiative. This essentially is a program that seeks to deal with the consequences or manifestations of cardiovascular disease and reduce it at the primary care level. So you are going to see your primary care doctor, and from that point, preventative steps can actually be taken. And this could also be applied to alcohol use. National alcohol policies. So one of the most heartbreaking things that I learned today was one of the first studies that showed how young children were and how they were reporting vomiting and stuff like that on alcohol. That's quite heartbreaking. There needs to be development and proper implementation and enforcement aimed at reducing alcohol consumption by actually enforcing the minimum drinking age. What about educational campaigns? So conducting educational webinars, seminars, campaigns targeted at healthcare professionals. This aims to update healthcare professionals. It can also influence drinking habits and educate the public at large on the responsible alcohol consumption. Research and policy impact. So we should be encouraging research on alcohol-associated diseases and their impact based on socioeconomic class, ethnicities, demographics, age, gender, etc. This is very important because one of the tenets of public health is equity. It's equal access for equal need. And there are individuals who have different needs in the society, individuals who may be more at risk of alcohol use disorder than others. Support groups. So these establishing alcohol support groups for patients to share experiences. And this is actually shown to increase the outcomes of these patients, both in terms of their quality of life, their relationship with their healthcare provider, treatment experience, and it also has shown to reduce the relapse rates. In conclusion, this overview of systematic reviews, I hope it provided a comprehensive systematic synthesis of evidence regarding the risk of developing hypertension with alcohol consumption. I think that it was evident through looking through all of these studies. We found that alcohol use definitely influences the risk of hypertension. And the findings of this overview of systematic reviews indicated that the development or progression of hypertension varied according to gender, race, and region. Again, I still stuck this in here. It is unclear whether there's a protective effect on females or not. I'd like to leave you all with something. It was a conversation between me and Professor Maharaj the first day I met him, right? And he was saying, if you go to a wedding, you drink. Your child born, you drink. It's normal to drink when good things happen. But also if you lost your job, you lost a family member, it's also normal to drink when bad things happen. But even if you meet up your friends as a normal day, you're not gonna lime without a bottle. So I'll leave you all with a question. If it's normal to drink on your good days, and it's also normal to drink on your bad days, and it's even normal to drink on ordinary days, then is the drinking really all that normal? Thank you.
Thanks very much, Mr. Ratan Singh, for a very enlightening umbrella review of all those studies and, by extension, patients that you would have examined by looking at those studies. So, we've covered a lot today, and we saw that alcohol really exerts an effect on the body and the systems, from chronic diseases all the way to unintentional injuries, intentional injuries, etc., etc. And hypertension, as alluded to by Mr. Ratan Singh, is just one of them. And we want to thank him for his presentation. Of course, wish him all the best for his final MBBS exams, which are just around the corner. And thanks for taking the time out, especially during this busy time for you. And believe it or not, colleagues, the last presentation is upon us, and it will be delivered by a colleague of mine at the University of the West Indies in Augustine, and she is none other than Dr. Arlene Villarreal-Stewart, who is a lecturer in the School of Pharmacy, and she would have recently supervised her team of Year 2 medical students, and they look specifically at alcohol as a risk factor for anxiety and depression. So again, alcohol continuing to exert its effects on different systems, including the mental health of our population and, by extension, everyone. And I want to really welcome, for the last presentation here this afternoon, to the stage Dr. Arlene Villarreal-Stewart for her presentation entitled Investigating Depression and Anxiety Among Medical Students, Alcohol Use, a Related Factor.
Right. Good afternoon, everyone, online and in person. So, ladies and gentlemen, esteemed panel and fellow attendees, today we gathered to discuss a critical concern that resonates not only within the academic and medical communities, but in society as a whole. So, the scope of our project looked into the prevalence of depression and anxiety amongst medical students, and our focus will be on the students at the University of the West Indies St. Augustine campus, years 1 to 5 in Trinidad. So my name is Quaishon Mayers, and with me to present today is my fellow colleague and group member, Mr. Prakash Singh. So we termed, as part of our Year 2 group project, our group name, we call ourselves the Mindful Medics. So without further ado, let us embark on this critical discussion about the prevalence of anxiety in medical students at the University of the West Indies. So before we get into that, As stated before, the title of our project looked into the prevalence of depression and anxiety in medical students at the University of the West Indies, St. Augustine campus from years 1 to 5. Now, from that project, we looked into 5 different sections, and we were able to draft a sub-paper from it, which we will be presenting at this conference today. And that paper was entitled Depression and Anxiety Amongst Medical Students and Alcohol as a Related Factor. Right, so of course we can define mental health with a WHO definition. However, the prevalence of depression and anxiety is concerning. It affects 3.8% of the global population, with a staggering 27% observed among medical students. So this discussion is vital as we explore the impact of medical education and external pressures on the mental health of medical students and the effect that alcohol has on it. So I'd like to emphasize the alarming prevalence of depression amongst medical students. So acknowledging that there are stressors of medical education coupled with external pressures contribute significantly to the declining mental health amongst medical students. So we must acknowledge that a study in Trinidad as a significant step forward, finding the solutions, and by investigating the prevalence of depression and anxiety, this creates a foundation for change. So I stand before you to proudly affirm that we have not only set our aims high, but have also been successful in achieving them through rigorous research and documentation in our research paper. Our project objectives were clear: to delve into the prevalence and associated factors influencing depression and anxiety and how medical students alleviate these issues within the University of the West Indies from their first year through their 5th year within Trinidad. So we aim to assess the trends and distinguish initial influential factors and research those that contribute to the decrease in anxiety and depression. As these students progress year by year, our comprehensive investigation not only met but exceeded these objectives, shedding light on the critical issue of mental health within our academic community. So as you glance at these 2 intriguing graphs currently displayed on the screen, I urge you to keep these visual representations at the forefront of your minds. Although they may seem vague at this point, rest assured that we will have compelling a narrative to unravel in due course. So, the design and settings of our project. So our research is founded on the robust cross-sectional study design, a strategic choice made with the utmost care. So within this framework, we meticulously crafted a questionnaire, the backbone of our data collection, and composed of 6 distinctive parts. So the first part, demographics, granted us invaluable insights into the personal characteristics of our participants. We then delve into the realms of mental health with 2 significant sections: depression factors and anxiety factors, exploring the intricate web of emotional well-being. The inclusion of the Oldenburg's burnout inventory is our attempt to comprehensively examine the exhaustion and fatigue experienced by our subjects, which is crucial, especially in high-stress environments like medical education. So we have also recognized the importance of addressing substance abuse, which led us to the inclusion of the CAGE substance abuse screening section. So this section allowed us to consider a wider spectrum of factors that influence the mental health of our participants. Lastly, we implemented the Hospital Anxiety and Depression Scale, the HATES test, a clinical instrument widely acknowledged for assessing anxiety and depression levels. So this final part served as a diagnostic tool to gauge the psychological health of our subjects accurately. So as we move forward with our presentation, keep in mind the intricate design and careful consideration that went into crafting this questionnaire. It is not just a series of questions, it is a window into the complexities of mental health, landscape of medical students, and the factors such as alcohol in which these students engage in to alleviate the stresses caused by medical education. So our study cornerstone is an online questionnaire, thoughtfully designed for the diverse student body spanning from year 1 to 5 in medical education. So the data collection spanned from January to May 2023 and has encompassed vital facets like gender, age, and the declimate domain of mental health. So in essence, our approach is to meticulously design to combine primary and secondary data, enhancing the validity of our study. The multidimensional perspective we obtain from this approach makes us better equipped to delve into the complexities of mental health in medical education and factors such as alcohol, in which students use as an alleviating factor. Now, to go into the findings of our project in more detail, I'd like to call my colleague, Mr. Prakash Singh, to continue with the presentation.
Thank you, Kushan. Good afternoon, ladies and gentlemen. So now I will be delving into the diverse demographics of our study participants. Yes. Okay. So a remarkable 61.6% of our participants were female, totaling 178 individuals who contributed to our study. Following closely was 36.3%, and those are males, comprising of 105 participants. Now, we turn our attention to Figure 2, where we explore the age dynamics within our participant pool. The vibrant majority, 37.4%, were predominantly aged 21 to 23, represented by a robust 107 individuals. Ages 18 to 20 contributed 19.9% with 57 participants. And notably, those aged 24 to 26 emerged as the second largest group, constituting 92 participants. Turning to Figure 3, as we talk about the year of study within medical school. The heartbeat of our research, Year 2, pulsates with 30.4%. In contrast, Year 1 claims its space with 14.5% and Year 3 with 18.7%. Year 4 and Year 5 students stand shoulder to shoulder, comprising of 18.3 and 18%. So in conclusion of our demographic findings, our research not only unravels the fascinating diversity within our study, but also underscores the dynamic interplay between gender, age, and academic progression. These findings will contribute significantly to our understanding and also pose intriguing avenues for further exploration. Moving on to our depression findings. As we dive into Table 1, we unravel the complex emotions and experiences reported by our respondents. A significant 35.6% expressed feelings of depression, laying bare the profound impact of our mental well-being. This, my friends, is very concerning data. I would like to let you all ponder on that for a minute. Further, 42% reported experiencing a diminished interest or pleasure in activities several days a week. Digging deeper into the emotional landscape, 35.1% revealed feeling bad about themselves for several days, and 30.9% experienced difficulties concentrating, shedding light on the cognitive challenges accompanying these emotional states. However, these findings take a somber turn as we uncover that 33.9% of the respondents admitted to having self-harm thoughts several days a week. This not only underscores the real-world impact of depressive experiences, but also emphasizes the importance of addressing these challenges holistically. Remember, these are medical students, the future doctors of society. Moving on to the Oldenburg questionnaire. In our exploration of these responses, a noteworthy pattern emerges. 10 questions garnered agreement from a substantial group of medical students ranging from 95 to 165 individuals. Of particular interest, a robust 146 medical students expressed a strong agreement regarding the need for more relaxation time compared to in the past. Additionally, 114 medical students articulated feelings of being worn out, hinting at the demanding nature of their academic pursuits. This is the life of a burnt-out medical student, and it is very common these days, and the workload is only increasing. Contrastingly, a notable 163 medical students expressed that they don't perceive their work as a positive challenge. These responses show the intricate balance of medical students and how they navigate between the demands of their studies and their personal well-being. Moving on to anxiety, something I'm experiencing right now presenting in front of all these distinguished individuals. An overwhelming 91.7% reported experiencing feelings of nervousness or anxiety several days a week. And this correlates with the challenges such as difficulty relaxing, restlessness, and heightened irritability. Notably, 32.5% of students experience a persistent fear that something awful might happen to them several days a week. These findings highlight the intricate relationship between academic demands and students' well-being. And I remember what we learned in Year 1 ethics. We all know that patient care comes first. But don't you think as doctors that we should be in the right frame of mind to deliver the best healthcare possible? Moving on to the CAGE findings. This provides a glimpse into the relationship between alcohol consumption and mental health among 289 students in our study. Remarkably, 29.4% of students turn to alcoholic beverages monthly or less as a coping mechanism for depression. Notably, the most common consumption falls within the 5 to 6 unit range, accounting for 26.6% of the responses. Delving into the CAGE substance screening, 85 students reported using alcohol to manage their anxiety and depression. Encouragingly, a majority, 67.5%, never faced difficulty, stopped drinking, or experienced memory lapses with their alcohol intake. Of particular concern is the revelation that within the drinking population, a significant 79.1% felt no concern expressed by their friends, family, or medical professionals about their drinking habits. It now becomes crucial to extend care and guidance, recognizing the complex interplay between alcohol use and mental well-being. Moving on to the contributing factors of anxiety and depression. The top 3 contributing factors for anxiety are expectations and opportunities for social mobility, family pressure, and the lack of relaxation or exercise, and control over their daily schedule. Notably, alcohol misuse is identified at 15%, underscoring its role in this complex landscape. Transitioning to the alleviating factors of anxiety and depression, music emerges as a significant factor, followed closely by sleep, and also by the role of sports, exercise, physical activity, religion, partying, and television. The correlation between these findings suggests an interplay between the challenges contributing to the anxiety and the diverse strategies employed by students to alleviate it. Moving on to conclusion. This study delved into demographics, depression, and anxiety among University of the West Indies medical students, revealing a predominantly female early 20s population. It discovered that students' level of depression and anxiety mirrored those in other countries, with alcohol use being a contributing factor. Interestingly, students hesitated to express certain symptoms, possibly due to the psychosocial challenges faced. These psychosocial stresses were linked to anxiety among the students, emphasizing the imperative need to address these issues in medical education. The study underscores the importance of fostering a supportive environment and suggests that future research should be explored, targeted interventions to enhance the mental health of medical students. Moving on to recommendations. So in terms of the awareness gap, medical students are mostly unaware of the counseling and psychological departments within the Division of Student Services and Development. There's a strong need for the improved promotion of the CAP services. In terms of promoting accessibility, there is a need to explore alternative channels for CAP services. Suggestions are to utilize WhatsApp, My Learning, or other online programs. Ensuring easy access, regardless of location, is important. And for regular screening, consider implementing regular mental health screenings, as there is a high prevalence for anxiety and depression among medical students. Early intervention and support is crucial for the overall well-being. And lastly, for acknowledgements, before we conclude, it is essential to express our deepest gratitude to those who made this research project possible. Dr. Arlene Verrill-Stewart, our principal investigator, and Ms. Marsha Ivy, our course convener, have been pillars of support and guidance. To all the students who contributed to this research and questionnaire, we extend our sincere appreciation. In closing, we acknowledge and thank our mentors and contributors, and their collaborative spirit has propelled this research forward. Thank you.
Okay, thanks very much, gentlemen, and your supervisor, Dr. Villarreal-Stewart, for that very enlightening presentation. Certainly food for thought, especially for us staff at the UWI, as it relates to alcohol use amongst our medical students and the implications of mental health issues like depression, anxiety, and dependence. So we certainly will know that and take it under advisement. So colleagues, we're near the end, just a few minutes left, but we do have one question posed on the online chat, and I believe that question is directed to Prof. Reed. So Prof. Reed, I don't know if you want to answer there, if you want to come up, but I'll probably read out the question for you. I'm hearing of grams being used. Why not milliliters? With respect to your data. I wanted to know why was there a preference to use grams as opposed to milliliters?
Okay, thank you. Thank you very much for the question from the online viewer. The data was presented because it followed the WHO collaborative study, which used grams. But if we want to get a good understanding of the number of standard drinks, it is actually better to look at the absolute amount of alcohol in grams. So there's actually a little calculation you can do so that when we speak about drinks and we speak about beer, we speak about whiskey, absolute alcohol is a standard quantity across all of these different types of drinks, which allows for comparison. But the short answer is that that is what was used in the study generally, so we continue to use it. To facilitate an understanding, I did the translation to number of standard drinks as the presentation went on.
Okay. Thanks very much for that response, Prof. Reed. Attendee, I hope that would have provided the appropriate clarification to your query. There aren't any more online questions. Can I ask the in-person audience if they have any questions to pose to this afternoon's presenters? Yes, Dr. Deet.
Yeah, I just wanted to say, firstly, I love when medical students present. I think it's never easy, but I just want to say if you want to translate it to Barbados, you give me a shout, we can make it happen. If you want to do it in our population, because I think that's very worthwhile. You guys did a great job. I wanted to ask Professor Reed, I loved your study. I couldn't help but notice, though, you mentioned 6 hours. So I wanted to know why you chose that. And then I noticed in your limitations, I can't help but think that these people are intoxicated. So I have difficulty getting quality retrospective data without recall bias. So these people are essentially partly or fully intoxicated. So how did you take that into consideration? And could they truly give informed consent as well? All of these things were kind of going through my mind. So I just wanted to know how you accounted for that.
So thanks once again for the question. And this study was really limited methodologically by the bigger collaborative study, okay? So we too had concerns about the 6 hours, as I alluded to, because there were many patients that the field interviewers encountered in the emergency departments who had obviously had alcohol to drink, but were not included in the study because of that specific inclusion criterion. I think that the idea was to be sure that you could relate the injury to the use of alcohol. So if you look at when alcohol is consumed, how it is metabolized in the body, most times within a 4 to 6 hour period, you find that the levels of alcohol in the blood tend to decrease almost back to pre-drinking levels. So the 6 hour was really to capture the possibility that the injury was related to the alcohol use. Now, the exclusion criteria included those patients who would have been cognitively unable to respond in terms of giving consent and so on. And even though generally we found a very high rate of high levels of consumption, there were many people who had had 1 beer, 2 beers, 3 beers. So the recreational use was there. So most people were actually able to engage, and we did not have that issue of intoxication. However, the limitation is acknowledged that self-report may have been blurred or skewed because of the influence of the alcohol.
Fantastic, thank you. So then my follow-up is, did you have an upper limit when you did the breathalyzer test? Did you have a limit which you said, okay, if we get this amount, we're not?
No. There was no upper limit to the breathalyzer. We simply went by the engagement with the patient and their cognitive capacity.
Oh, amazing. Thank you so much.
Thanks very much, Prof. Reed and Dr. Date. Any other questions from in-person attendees? Okay. So, colleagues, we're drawing near to the end of this evening's proceedings, but it really would be remiss of us if we didn't give the brainchild, the crafter of today's proceedings, the last word. So I know he had a long day and a long week and probably some long months putting all of this together. And he just wishes to really deliver a brief vote of thanks before we conclude today's proceedings. So I welcome to the stage yours truly, well, none other than Professor Rohan Maharaj, or Professor of Family Medicine. Thank you.
So, thank you all for coming. And the biggest round of applause, please, goes to you all for staying. Thank you very, 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 very much. You know, I go to these talks and everybody runs out by lunchtime, and yet still you guys are all here. Thank you so much for coming. Thank you for staying and for supporting this venture. Alcohol is not a popular thing for us to be studying academically, and the fact that you guys are here and thinking about it, I know Sandra's been around with this for many years. It's been an area of her special interest, and I really appreciate you coming out and sharing a really wonderful study. It's very, very well done. Thank you again. Thank you to all the presenters. There are many people who were behind the scenes to make this happen, and I really have to say thank you to them. The Faculty of Medical Sciences, the Healthy Caribbean Coalition, so Trevor, Hassell, Maisha, and so Trevor and I sat down several years ago and came up with this idea together that we would do this Caribbean Alcohol Reduction Day, and we've been trying to build on it, and I think this is the biggest that we've had so far, and I really want to thank them for giving me support and also being part of the team. I want to thank our head of department, Professor Packer, and the members of the paraclinical sciences who've been some of the volunteers in the background, helping with the task and so on that had to be done, helping to make sure that we are comfortable. I want to thank the UE Campus and Research and Publications Fund that provided us with some money to rent the site and to pay for some of the services that we've had. The MPH program and the Family Medicine program for giving support through the coordinators of both of these programs, Dr. Khan and Dr. Mutilal, who really been my right and left hand, have really helped to keep me sane while we've been going through the process of getting this all done. I really want to thank all the presenters and researchers who I reached out to so many months ago. Some of them were slow in getting back, and yet still they've all turned up and really have made an impact. We've lost a few along the way. Dr. Ms. Lakeview, who was from Yale University, wasn't able to perform, to come in or to present. And one of our year 2 students who was really very stressed out in the year 4 clerkships. So in the conference committee, I need to thank Mr. Karen Salvery. Karen, thank you very much for your support. The moment I said we're going to have this, Karen was there saying, what do we need to do? Thank you very much, Karen, for being here and being here at the end. Ms. Sabrina Mahabir and Ms. Vishala Christopher, who are 2 research assistants that we were able to hire because of the fund and have helped us in so many ways to keep our heads above water. Michelle Yan, Patrick Harper from the University Inn and Conference Center, who the moment he said we'd like to use your facilities, really was there to give a hand and to make sure that everything ran smoothly. I want to thank our IT guys. I don't know these fellas at all. At least I didn't know them. But they made everything so smooth. Where's Nigel? Nigel, thank you very much for being so personable and for really making it not difficult. When you're doing this kind of thing, you really wonder, how I have the right people? Are they going to do what we need? Are we going to get all the streaming done? And how can we have the microphones work? Listen, this today went smooth. Did you find? Everything. Thanks a lot, guys. Really, you made a difference. Mr. Alvarez, when I came in here yesterday, I met this fella. I said, boy, this fella looking familiar. I know Mr. Alvis's family for many years, and they've been my patients in Arima where I practice. And Eric has been to my office, even though I want to look at the card and see how long you hadn't had the last visit. But thank you very much for, again, a wonderful family who I've known and loved for many years. His brother is a pastor, and their family is related to another family that I've looked after, and it's been really wonderful to meet him in this environment. Miss Wendy Maynard from marketing, I don't know, she's not here. Wendy really made a lot of difference in terms of providing the marketing, did the logos and the screenshots, and a lot of the background work. And then at Healthy Caribbean Coalition, so Trevor, Hassell, Maisha, Dr. Date, for coming from Barbados to come and make sure we did our job. Isn't Stephanie something? Thank you very much, Stephanie. And a couple others behind the scenes, Doriel Quintine, Miss Danielle Walwin, and Mr. Ian Pitts. If I've missed out anyone, I apologize. And through it all, I want to thank my family, my daughter who's here, my wife who's not. We were supposed to go and have one of our Dr. Baba was supposed to present his film as a premiere today at the faculty. He's done a film interviewing people on how COVID impacted on their lives. And this film was supposed to premiere this afternoon at the Faculty of Medical Sciences. But you know what? People have gobbled it up and said they're going to distribute it to the Caribbean, so you can't present it as a premiere here. Isn't that amazing? So we might be with the next Oscar winner, or maybe our Caribbean Oscar. So I want to thank you all. Thanks, everyone. I think we still have a few people online. 43 people are still online at this time of the day. We are almost on time. If we are probably 15 minutes to half an hour late, imagine that. So there's only one thing left to do. One thing left to do. Right, Stephanie? We're all going to come up the front and take a photograph. Yeah? And I want to thank you all. You will all get an email from me. Part of it is going to say thanks. Part of it is going to say, how can we work together in the future? What's the plan? Can we make this into a next level event? Maybe a brainstorming, maybe finding a few key elements, maybe roping in some of our young minds to say, look, can we take a few projects and take it forward? Okay? But thank you again for your coming. Please take one last round of applause from my heart to yours. And come, let's have a photo. You come in the front, is that okay? Can we move the camera so we can have...
Forever.